and with like your janky arm. Waiting on Bart to get back. I wasn't expecting you guys to go with that quiz so fast. Lisa told me it was going to take y'all like 20-30 minutes to do that quiz.
I keep it. Well, hers is that she won't sign. But
Yes, well, she also can't sign legally.
right.
So, just say that you put you down and then. Oh,
So who was K?
that wasn't Kay, it was Fran.
Fran.
Fran and.
Dr. Fran.
Who else was there? Heather was there. There's another nurse there too. Oh, wow, there's so many. Is everyone else up? Cool. We're going to talk about respiratory emergencies today. See if this works. Ah. So, we have a little bit of shit to go over today. There's going to be like a little introduction from your book. Then, I don't like I would have fixed it. What was that?
So let's just go drink.
You can, but it's kind of important
I
stuff.
know.
Then we're going to go over that textbook case review. You don't need to open up your books for your case review, because I think it's stupid that there's like a full-on page that we have to try to have you guys read and then remember, and then answer questions about. So I paraphrased it for you guys on a slide, because I'm awesome. Then we have to go over anatomy and physiology again. We're going to talk about some general pathophys. Then we're going to go over just like how to assess respiratory emergencies, what to look for, what you're going to see. We're going to talk about specific disease pathophys. And we'll conclude that textbook case summary, and then I have a real EMS case study that you guys can hopefully learn from. So, respiratory distress is one of those things that can rapidly deteriorate into respiratory failure and arrest, and we're going to talk about the differences between those today. And obviously, if you're not breathing, you're going to die. So, respiratory distress interferes with the ability to deliver oxygen, which you know is going to inhibit metabolism. And the stress of that is going to cause you to amp up your body mechanics, and it's just going to potentiate that problem. Eventually, the inadequate metabolite is going to turn through anaerobic respiration. You're going to have a buildup of lactic acid, if you guys remember that Krebs cycle that we talked about in the introduction to the human body lecture that I taught. It's going to increase that lactic acid, which is acidotic. You're going to shift the pH, go into respiratory acidosis, and all of that's just gonna potentially, or like exacerbate your ability to not restore homeostasis. So, the end goal here is to quickly recognize difficulty breathing, intervene with it with your proper sources, either nasal cannula, non-rebreather, definitive airway access, ensuring the patient has an airway, mentally as needed, and understanding how anatomy, physiology, and pathophysiology is going to impact a patient exhibiting signs of respiratory distress. Am I going too quickly for this introduction? Cool. So, your case study, and I'll read it for you guys, so you guys don't even have to worry about reading. 60-year-old male with a history of COPD complaining of difficulty breathing. On arrival, he appears short of breath. He's wearing a nasal cannula, sitting on the edge of his sofa, with his hands placed on his thighs to support himself. What is that called?
Tripod.
Cool, so he's tripoding. Respirations are labored. The patient barely acknowledges EMS. Is that significant?
Yes.
Why is that?
Altered mental status.
Yeah, what's causing that?
Hypoxia.
Probably hypoxia due to the short circuit, right? His ears and lips are dusky blue color, and he is using the muscles on the side of his neck to assist with breathing. Okay. And the patient coughs up some rusty colored sputum. His skin is hot and moist. EMS asks, "How are you today?" And he replies, "Can't seem to get a breath." I'm a bad actor, whatever. He gasps. Okay, so based off this, like, I don't know if she's gone over this, but the whole sick, not sick, right? What's your 5-second impression? Is this guy sick? Is he not
Really
sick? And do you think he's just having respiratory distress? Is he going into like respiratory failure, respiratory arrest?
Headed towards respiratory failure.
Okay. And why do you say that?
not being able to finish a
Because of the
sentence.
mental status, the hypoxia, the accessory muscle use, all of that, you know.
Cool. Yeah, so this part should just be like, very much akin to like your EMT class, a kind of refresher on that, but yeah. So you notice that he has some cyanosis of the lips, which means that, okay, so he's starting to shunt a little bit, right? He's hypoxic, so you know he's not getting enough oxygen to his brain. He's tripoding using accessory muscles, so he's really working hard, which means like he is gonna head into failure at some point, because he's gonna lose the ability to maintain that after a while, because that takes a lot of effort. So, if you guys notice, I took out all the dudes' names, because I don't think you guys care about Hank, the AEMT from the Brady textbook. So the family on scene reports that the patient's bronchitis has been acting up since last night. He started having increased difficulty breathing with chills and fevers this morning. Family called 911 and he became confused with increased shortness of breath. Your patient is an obese man with bilateral pedal, I forgot to say edema. His lung sounds are rhonchorous. Do you know what that is? It's the plural of bronchi. You know what bronchi are? If you don't, not a big deal, we're gonna talk about that today, but just curious. So you know it, what is it?
I forgot since you told me.
Okay, cool. And wheezy, scattered throughout with basilar crackles bilaterally. And when I say basilar crackles, what does that mean? Okay. Respirations are 30 and labored. Heart rate is 124 and irregular. His BP is 164/102. The SAT is 82 on 3 liters. Is that SpO2 like concerning to you guys?
Yeah,
Okay, why?
that's severe hypoxia. And
Needs to be checked out, boys. I'm using boys as a unisexual term. So please do not be offended by female brethren, sisters, whatever. Alright, so you have to remember, a patient is, this guy has COPD, right? We know COPDers typically have low O2 sats. So, I am a little concerned about it, but I'm not as concerned about it, because like, he's on 3 liters with a sat of 82. So how much did it go down, right? Because like, we don't know what his baseline is. He could run at 85. But yeah, good thinking, I like that.
So, can I ask something, so with COPD, what do you, like, typically see for an O2 set? Like,
Depends, usually it's like high 80s.
yeah, okay.
Like, it's not uncommon for COPDers to sit on like 88, 89. Who's up? We're gonna call. Yeah, one of the one of the EMTs.
It's not here?
Whoever's on duty, come on duty, you gotta go.
Okay, you're on. I was gonna say, I don't come on till
Yeah,
7.
he's still on.
You don't come on till 7, right? Okay.
Alright,
I didn't even plug it in yet.
tell me that happened. I was just like, I'm not. I was hoping that he wasn't telling me to go. I was like, I'm not.
I'm on
fucking
tonight, but not till 7, so.
Alright, so we're gonna start that anatomy and
What does
physiology
he think?
review.
They're just gonna one-man it?
Who?
Does he think they're just gonna one-man it?
I think he forgot that he was on because I was down here and not moving. I think he thought that it was 1900 already. What was that?
So that's
I thought you were going for an age joke there, and it really threw me off.
Well,
that,
I've heard- I
that's
don't
why
know.
that's
I've
why
heard-
he sat there and goes when the call goes out, right?
I've heard rumors that been doing some great work here. So. Anyways, moving on. Anatomy and physiology review. So we know that the airway and the respiratory system as a whole is responsible for providing O2 to the body's tissues, as well as removing metabolic waste. Specifically, what we're concerned about today is CO2. And you can break it down into 2 sections. You have ventilation, which is responsible for the movement of air in and out. Ventilation does not equal oxygenation. And then you have oxygenation, which is movement of oxygen in the body's tissues. If you remember that from the review lecture, that's all based off diffusion, right? And those specific gradients that we talked about. So respiration is the exchange of gases between its organism and its environment, and there's 2 types. You have your pulmonary respiration, which is essentially external respiration, which is an exchange of gas between lungs and capillary blood. And then cellular respiration, which is an exchange of gas between the capillary and the cells of body tissue. So you have two different types going on, right? And it kind of plays into the pathophysiology of some of how the diseases are going to break down. There's some diseases that are going to affect alveoli, which is going to impact which one, pulmonary or cellular respiration? Pulmonary, right? Because it's going to interact with the ability for the lungs to send that oxygen to the capillaries, right? So that's the only reason why we're breaking this down, is because understanding at the very basic level that you can think of respiration two ways to help when you're trying to understand the clinical manifestations of some of these diseases. So, and another refresher, you're gonna hear this a lot, especially you guys haven't done cardiology yet, right? Well, you're gonna get the shit beat out of you with perfusion and cardiology. But perfusion is circulation of the blood through capillaries and blood vessels. I'm mentioning capillaries specifically today because that's pretty much all we're worried about at the anatomical level when it comes to respiratory problems. And this is all dependent on multiple factors: adequate blood volume, intact pulmonary capillaries, and the effect of pumping of blood by the heart. If your heart's not pumping or not pumping blood, if you have heart failure, it's not as effective. Certain MIs will cause that as well. And we'll briefly at the end, the very final case review, I have one slide that's kind of advanced stuff. But like if you guys want to learn some like kind of cool fringe stuff, like that's what it's there for. If you guys don't, you guys can leave so you guys don't get confused either way. So remember, the respiratory system is responsible for delivering that oxygen. That oxygen is needed for metabolism. And there's two types of metabolism. You have your aerobic metabolism, where energy is or glucose is technically broken down into pyruvic acid, which is then dissolved in oxygen to create energy, right? And anaerobic is where glucose is broken down, creating pyruvic acid, which then there's no oxygen, so it gets converted to lactic acid. So, this is the fancy picture of the upper respiratory anatomy. We're going to talk about it in depth, but understanding that the nose and your mouth are connected in terms of respiratory anatomy. So, we're going to start off with the nasal cavity. So, the hair, the little cilia-like fringes, prevents large particles from entering. That's important when you're trying to think about stopping disease and the spread of pathogens. The turbinate bones, which are these guys up there. They kind of like those like little ridge-like things inside the sinus cavities. Go back. They warm, humidify air. It helps trap mucus and keep it inside the sinus cavity. And the little cilia helps push all that extra stuff down to the pharynx. The sinuses, not only, the main focus, honestly, is like to reduce the weight of the skull and make your skull not be super fucking heavy, because you have to think about how much neck muscle it takes to hold up your skull. You have different types: maxillary, frontal, ethmoid, sphenoid, and all of those like can become impacted with mucus and stuff like that, especially if there's a pathogen or a histamine release, which is why you feel crappy when they get plugged up and get like the sinus pressure. The pharynx connects the nasal and the oral cavities with the larynx, and the larynx is also what a lot of people just call like the voice box, but it's not quite the same. But that's like what you'll hear a lot of people like commonly call it. It allows passage of air into the trachea. So the pharynx it gets subdivided into three different types: your nasal pharynx, which obviously so the nose, the oropharynx, and the mouth, and then the laryngopharynx, aka the hypopharynx, and that's important because that's place your supraglottic airway devices, your eye gels, King Airways. Do you guys go over combi tubes?
I think we touched on them, but
Yeah, combi tubes are the stupid antiquated device that has like two tubes that if you ventilate the stomach in one, you just kind of like plug it up and then the theory is you just use the other one, and then you're ventilating the trachea.
I think we landed on they're not in the protocols anymore.
They probably aren't, but like, I don't know. When I took my intermediate exam, we still used it, it was stupid. So the larynx is superior to the trachea, it houses the vocal cords. The epiglottis sits above the larynx, and closes during swallowing. If you are exposed to a bunch of cold water all at once, there's a phenomenon called the mammalian diving reflex, where the glottis like slams shut to protect itself because it thinks you're going to be drowning. And then the glottis is the opening between the vocal cords. There is one other thing which I didn't touch upon, but if you guys go to the paramedic level, there's a little tiny nub called the vallecula. I don't know what they call it. Let me see if I can find the airway mannequin guy. Little mouth. If you guys go to the paramedic level, there's this little flap, and I'll walk around right here. That's actually a real thing inside your throat. And it's called the vallecula. And depending on like how you go to intubate a patient, like depending on what blade you use, you're actually affecting that vallecula. And that's what allows us to get direct visual like appearance of the vocal cords, right? That's what allows us to see it. Because you either insert a blade in between the space between the tongue and the vallecula and lift up the actual airway that way, or you fit it over the vallecula and lift up the entire airway that way. So, if you guys work in a hospital, or if you guys work with paramedics that use I know a word, but we have video scopes. So if you see us do it, that's why you see like in TV, they'll go like this, lift up the airway. But that's how it works. I didn't mention it because it's not really pertinent to you guys, but like kind of being aware that there is another structure inside the larynx. It's kind of good. So your trachea is surrounded by cartilaginous rings. It sits anterior to the esophagus. And it bifurcates into the bronchial streams, which divided the carina into the left and right main stem bronchi. If you notice, your right main stem is slightly straighter than the left main stem. Once again, not so much important for you guys, but for those of you guys that are going beyond the advanced EMT class, if you do an intubation, or even if somehow you jam like a king airway into someone's trachea and it's long as fuck, you can actually get something called a right main stem intubation, where you actually directly inflate a cuff onto the right bronchi, and you won't see bilateral chest rise. So good thing if like you guys are watching medics run codes or something, if you notice that uneven respiration, that's probably why, because we went too deep. So the bronchial trees are broken down into 3 different sections. Your secondary bronchus, technically there's 3 trees on the right and 2 trees on the left. And that comes down to the segmental or the tertiary bronchus. And then the smallest little trees that come off that called bronchioles. And those don't have any cartilage, so those are just like little noodle-like structures. I don't actually know, I've never felt up a lung, but. Oh, that's what I should do. Damn it. My girlfriend has a full-on video of her inflating like a dead dude's lungs, like with his chest cracked open. She uses for training. I should have asked her for it. She made your case study at the end. It's pretty cool. Anyways, so the bronchial trees, remember, they go to the terminal bronchioles, respiratory bronchioles, just a fancy way of saying that those are the ones that actually have the alveoli on it, right? That's the only reason we're mentioning this. That's where gas takes place. And so the alveoli are actually these guys here, and they have these little tubes that attach to the bronchioles, which that's called the alveolar duct, which leads to the alveoli. And the alveoli are like these little tiny popcorn-esque little air sacs, I guess, where gas exchange takes place. And they're lined, I think the next slide actually has, no. And they're lined with a serous fluid known as surfactant. which prevents the alveoli from collapsing upon itself. It's produced in the body, and it's affected by nitrogen. So excessive nitrogen can actually cause it to dissolve, which would then cause alveolar collapse. So the respiratory anatomy of the lungs, you obviously have two, your left and right. They're separated by the mediastinum, which is this guy here. It's super, remember mediastinum? Because that's what's going to cause tracheal deviation and what? You guys remember from EMT class? What causes tracheal deviation? If you don't remember, we're going to talk about it today.
Is it tension?
It is tension pneumothorax, right? So it's enclosed in the closed by the diaphragm and the thoracic rib cage. It's suspended in the thoracic cavity, and pretty much biggest things there are like the bronchus, right? Because that's what we need to know, because that's what leads to the alveoli, allows for gas exchange, and then the pulmonary vasculature, because if you're not transporting blood, you're not transporting oxygen. Without oxygen, the system's useless. So, around the lungs, think of everything in the body as, I'm sure we've heard you guys talk, or you've heard us talk about this all the time, that organs are just sacs within sacs, right? So they're separated by two pleura, the visceral and the parietal pleura. Which one touches the lungs? Visceral?
Or, no, parietal.
No, you're right. So parietal is touching the thoracic cavity, and then visceral. And I always remember it as if you're looking at the patient, and the alphabet P comes before V. Just I don't know. It works. Then you have the pleural cavity and pleural fluid. So essentially, you have two membranes, right? And they're lined with this little lubricant. That's what the pleural fluid is, and it's literally just there just to stop it from rubbing and causing irritation. If it becomes irritated, it's gonna become inflamed. Becomes inflamed. You're in for a bad day. So that's also one of the causes of pleuritic chest pain. We're not going to talk about pleuritic chest pain today, but that goes along with cardiac and angina and stuff like that. Am I going too fast for any of you guys? This is all review of the lungs, so cool. And we have, I lied, 110 slides in this slide doc, so trying to power through it a little bit. So you have inspiration, the diaphragm contracts, moves downward, and that causes what sort of pressure? A negative pressure, which sucks air in. The external intercostal muscles raise the ribs. And why does that happen? Yep, increases the thoracic chest space. And other muscles are used, the sternocleidomastoid mastoid muscle. Where is that? Literally right underneath it, this we're gonna see. You're gonna see it right underneath the clavicle, and it also, as he's right, it goes right up along here. It just kind of sits like this. It's like one of those weird ligament type things. And then you have your pectoralis minor, and we're talking about the external ones, so the ones right around here. That's classically what people are gonna be talking about when they see accessory muscle usage. So inspiration, as Chris mentioned, the volume of the chest cavity is gonna increase. And all of this is affected by multiple different factors. Lung compliance. What do I mean by lung compliance? Oh, damn it, it's on there. I made this slide, but yeah. The ease at which lung expands. You can feel lung compliance. When you're ventilating a patient, if you hear me ask you, or if you ride with me, or if you hear your medic or your partner ask you, how do they feel to bag? If they're feeling normal, they feel easy, that means they have good lung compliance, right? If they're rigid, they don't really want to go, the chest wall's not moving that well, that's poor lung compliance. Some of that's caused by a variety of things. Could be COPD, could be the fact they took morphine. One of the side effects of morphine is chest wall rigidity. So it could be a variety of factors. It could be a foreign body airway obstruction. There's so many different things that affect lung compliance, but that's something that you can actually quantify and feel. So as lung volume increases, compliance decreases. That makes sense. If you fill up a balloon, the larger you fill it, the harder it is to blow it up. And yeah, I've already touched on the rest of that. So during respiration, because you have that negative pressure, the alveoli want to collapse, right? They're these little tiny sacs, they're little stupid buggers that they want to do the opposite of what they need to do. And that's why surfactant is produced, It's just meant to lubricate it and prevent the alveoli from collapsing. It is a membrane that allows diffusion, like across that ion gradient and across that membrane. Otherwise, you wouldn't have any sort of respiration happening. So total volume is the amount of air that moves in and out of the lungs. If you want to do the math, it's 5 to 7 milliliters per kilogram in the average adult, but most commonly it's just 500 mLs. It changes based off genders. Females have a slightly smaller tidal volume than men. And then I remember when I sat in on that class that Lisa taught, she was talking about anatomical dead space. And that's air that remains in the trachea, the bronchioles, the bronchi. No gas exchange takes place in any of that air, so it's just kind of useless air. And that's on average about 150 mLs. And that's the core reason why tachypnea is a problem, right? So if you take 10 breaths at 500 mLs, you're getting how much mLs of air?
3,500
10 times 500?
minus the dead space.
So it's 5,000 minus 1,500 gives you 3,500 versus 2,250. How much are you getting now?
$2,000.
So that's 1,500.
What did they say?
Meeting at the police department now instead. So that's 1,500 mLs less air, right? That's why we tell you guys, hey, if their respirations are too low, you need a bag for them. Granted, is that practical? No. But that's why we tell you guys that, because if you're not taking in 1,500 mLs of air, significant portion, that's a third of your average volume, if not more. So there is also some air trapped inside the alveoli that does end up getting diffused. It's kind of inconsequential. Yeah, it's negligible. So controlled breathing is, remember, respiratory center is located in the brainstem at the medulla. It contains chemoreceptors that are receptive to, or sensitive to your pH balance, the levels of PCO2. What does that stand for? I'm not gonna tell you guys, so we're gonna.
Carbon dioxide?
It is carbon dioxide. What was it?
What's in your blood?
Huh?
What's in your blood? Not what you breathe out.
I think it's the partial pressure of CO2 in CSF. So that's how it's going to be described in your textbooks. That's how it's going to be described if you get an ABG value, or if you do an end tidal. You're seeing your PCO2, right? That's what it's measuring. So an increase in your CO2 causes an increase in rate and depth of respiration. Why? Yeah, we'll wait a sec.
Wave it. No, Josh, wave.
What the fuck is that?
Huh?
Huh? Is he the transition series? No. That's what we should have used. But the state of Vermont did this transition series PowerPoints, and they were amazing. But this new book that she tried this year is garbage. What do you guys think of the actual textbook? The textbook itself looks fine,
It's fine.
but the teaching resources for it, huh?
Pretty repetitive.
Yeah, the teaching resources are awful. That's a weird taste. Going from drinking an orange flavored Monster to I don't even know what the white flavor is. It's delicious, but it just.
Drink water in between. Your palate will break.
I'm American. I'm gonna more Monster after my Monster.
He's working on a kidney still.
It's
No,
not
I have
fun.
great kidneys. Thank you.
You got a kidney?
Yeah.
That's why I said I have great kidneys. 'Cause because you like spinach so much.
So leaving water in your mouth.
See, one of what's never given me a kidney stone, the amount of kale I consume. I eat so much
I
kale.
have to cut down on my leafy green vegetables.
If like kale isn't on sale, I buy broccoli. That's, and if that's not on sale, my third choice is like green beans.
Asparagus is on sale right now.
I don't like asparagus because it makes my urine smell bad. And there's actually,
Embarrassed about how your pee smells?
but no, so there's actually a selective portion of the population, I don't remember the exact
Yeah, no.
percentage, that actually can't smell it.
Really?
Yeah, so like
Can't smell what?
the asparagus urine,
It's the asparagus acid. in the asparagus.
I mean, I've never,
you never ate asparagus and then took a
Okay,
piss
this
and
like
like
portion.
smell?
I've never noted it. Like, hey, what does my urine
Then
smell
you-
like
then-
today?
Yeah,
Yeah.
then you're immune to it. Like, trust me, you'll
You would
know.
Yeah, you would.
Anyone that eats asparagus
Maybe I just-
that can smell it,
What-
it's like, it's obvious. You're like, you take a piss, you're like, yeah, I thought I had asparagus.
Well, now I'm curious and I'm gonna eat asparagus.
You
No.
haven't smelled it by now.
Unless you're pissing
I haven't had
next to
asparagus in like 10 years. I don't.
Unless someone's pissing next to you, man, like,
Ow, it's so good.
oh, asparagus is great if like you're having like steak.
It's just good all the time.
No.
Yeah.
Kale is good all the time.
But asparagus is
I like
good.
winter kale more than summer kale, because winter kale is less bitter.
I'm not picky about greens. The only thing I can't do is cilantro.
I mean, I eat anything.
Like,
I will
cannot do
literally-
cilantro.
Well, the shops never even have good cilantro.
It's because
Ever.
no
I've
cilantro
been
is ever
there.
good.
Every time I go to that shop, they never have healthy cilantro.
It's because it's in
Like,
Randolph.
I say you're also looking for produce at Shaw's.
It's just, it's
In
close to my
Randolph.
house.
Not
What
just
else
at Shaw's.
No, at Shaw's in general.
No, because like the Shaws of Waterbury was fucking great. But the Shaws of
Great
Randolph
question,
is
man.
terrible.
Well, I don't like driving to Burlington all the time. I'm
What are you driving to Burlington? Exit 10 is Waterbury.
Trader Joe's.
Exit 1.
Trader Joe's.
California.
Yeah, you can go to fucking exit 18 and stop off at Lead. Or 19 if you want to go to West Lead.
Not good. Stick room. Talking about groceries.
Groceries.
Asparagus.
And if you guys like,
I will eat asparagus, I won't eat that dirt. but-
can you smell the
Do you smell asparagus piss?
yeah,
No.
you don't? Yeah, you're one of the few population that can't.
What, you just piss in here?
No.
You guys went upstairs, he went to the corner.
When in doubt, whip it out. Anyways, so an increase in CO2 causes an increase in respiratory rate and depth of respirations. Why is that? We talked about it once originally. Were you even here for that class? Because you, what? I don't remember if you were here for the first class I thought. Were you? Oh, it was like a month ago. Exactly a month ago today.
You keep track.
No, I have a folder and I date it based off the
Keep
handbook
track.
from the lecture.
Can you repeat what you asked? Because I totally tuned it out. Same on it.
I get that.
Sorry.
For Princess back there, as your levels of CO2 increase, your rate and depth of respiration increase. Wow.
So trying to get it out.
Just like trying to.
I was just letting you guys answer. I like how like students, when they answer questions, they ask in an inquisitive manner as if like they're unconfident in the answer because they don't want to get it wrong.
That's why we're students.
You guys are like, because you need to breathe? There's always like that upward intonation, it's like you're unsure. And a decrease in pH also causes that same thing because of the acidosis, right? Just trying to eliminate it, that's why it increases. But as you have an increase in the CO2, it's acidic, it's gonna drop your pH, one of the pH scales, inverse, which increases your rate of respiration. So, medullary signals are transmitted through the phrenic and intercostal nerves to the primary muscles of ventilation. It's a fancy way of saying the diaphragm and the intercostal muscles. Stretch receptors on the visceral pleura and the walls of the bronchi bronchioles inhibit the response so you don't cause barotrauma. So you have to think about that. We talk about you breathing, but we never talk about how your body stops the senses from saying stop breathing. Because like, if it just kept inflating, your lungs can only get so big before they pop, right? And that's odd. There's like these little tiny stretch receptors on the visceral pleura, which pleura? Camden?
The one touching the lungs.
Very good. On the visceral pleura, that stops it. It's like, hey, guy, this is good. You can stop now. And so that's what inhibits that response. And it's also good to know that we talked about the phrenic nerve because, like, knowing that nerves are impacted when you guys talk about neurology and trauma. I think when you guys talk about spinal trauma as well. You'll learn about like dermatomes, and you'll learn about which dermatomes that innervates, and like if you have a fracture at a certain point, you can actually inhibit some of that response. So that's why I mentioned the phrenic nerve. So also the carotid artery and the aortic arch contain chemoreceptors that are sensitive to CO2, similar to the brainstem. The aortic arch contains PO2, partial pressure oxygen receptors. COPDers, as we know, become accustomed to that increase in carbon dioxide. I don't know why I drew a blank there. So they live off that hypoxic drive that we talked about, right? So the decreased oxygen levels controls respiratory rate. Because if they're used to just having an abundance of CO2, it kind of defeats the entire control of breathing processes. So they get used to monitoring their respiratory rate based off their SpO2, not SpO2 levels, but their actual oxygen levels. And although I've never seen it, and no one I know has ever seen it, if you give high flow oxygen to a COPDer, theoretically they can become apneic because they're no longer registering that they have low oxygen levels. They think they have too much, so they stop breathing.
But that's assuming that the hypoxic drive is dead and not just decreased.
No, so even if it was in state, right? So everything about the hypoxic drive is what drives COPDers to breathe, right? If they have too much CO2, or too much oxygen, not CO2, right? Too much oxygen, they're gonna lower their respiratory rate. If they have too little, they're gonna speed it up. Just like how we do with CO2. If we have too little CO2, we slow down our breathing to increase it. If we have too much,
I'm
we
at the
speed
other
up.
way around.
So if you give them too much, the theory is it'll register that they have too much and they'll just stop breathing altogether. No one I know has ever seen it, even on people with ventilators where they can fuck around or shit like this. Like, I've never heard of anyone talking about it, but the theory is out there. The book talks about it, so just be aware of it. It won't affect you guys in your transport times. Once again, we even talk about like I know Jackson brought up at one point, the whole free radicals and oxygen toxicity. You're not gonna see that in EMS, like unless you're doing a transfer to Boston every single day on a patient that's been on oxygen at high flow for the past 16 hours, you're not gonna see it. Even if you put a patient on oxygen for 3-4 hours, they'll be fine. So. Alveolar gas exchange. So the alveoli are next to the capillaries. It's cell wall to cell wall. They're packed in there really tight, and it just diffuses across that membrane. And you can see like this is kind of what it looks like. The little tiny bubbles are wrapped inside those capillaries, right? They're interwoven. And then this is sort of what it looks like here. The alveoli is literally right up against that capillary, and then it diffuses directly through those cell membranes onto what is on the red blood cells that uptakes oxygen? Hemoglobin. It gets bound by the hemoglobin and then transported to the cell. Blind myself. Oh, damn it. Hemoglobin is on there, cheater.
I didn't see it. I was watching you over here.
Okay.
And if we don't know that by now, we're in trouble.
I don't presume it, that's why we go at such a basic level and go back over it every single time. So this is just sort of standard levels that you don't need to know for any testing purposes. I just thought it was interesting, so I threw it in here. So inside your alveoli, you have about 40 millimeters of mercury of carbon dioxide at any given time, and 104, right? Then, as you move to your capillaries, the deoxygenated capillaries have 45 millimeters of mercury and 40 millimeters of mercury of oxygen. So you see that it's still not even taking 100% of that oxygen, and in fact, you're not even, the CO2 is negligible. You're actually gaining very little CO2. You're getting what, 5? It's not bad. And the oxygen in blood obviously has to 40 because it picked it all up. So that's why, at the very basic principles, at the capillary level, why you're exerting 40 millimeters of mercury of oxygen, why that's important, is think of when would you need to use that excess oxygen during expiration. I had to figure out how I wanted to phrase that in my mind.
You're talking about mouth to mouth.
That's why mouth-to-mouth works, right? Because, yeah, you're getting rid of CO2, but you don't use all the oxygen we breathe in. Out of the 104, you're only using maybe, what, 75% of it? Maybe a little bit higher, I'm not doing the exact math in my mind. But, like, you don't use all of it, man. So it doesn't really matter. And that's why mouth-to-mouth works. It's not great, it's not as much as we would have liked, but it's better than nothing. So, as Chris mentioned, oxygen is carried by hemoglobin. Each molecule can carry 4 oxygen molecules, and when it's bound, it's called oxyhemoglobin. Increase in O2 causes increased binding with hemoglobin. That makes sense. Oxygen's there, wants to bind, transport to the cells. Oxygen is released from hemoglobin when there's a lower pressure of oxygen. And also, there's one other incidence that would cause oxygen to be knocked off of hemoglobin. What is that?
Monoxide.
Carbon monoxide. Carbon monoxide has a higher affinity for hemoglobin than oxygen, which is why. Sorry, Lisa just said. That's why, if you have an SpO2 monitor on a patient who was just inside like a fire or something, their stats might be 100%, but they might not be able to breathe that well because all of their red blood cells are saturated with carbon monoxide instead of oxygen. And SpO2 is just an infrared sensor, not infrared, but like a red light that gets shines through your fingers. It illuminates the capillary bed and it determines using color spectrometry how much of your molecules are saturated with a molecule. So it doesn't differentiate between CO2 or CO. It just is like, oh cool, 100% of your red blood cells are saturated with something. So that's why CO2 or SpO2 is not really reliable.
Now Dave said that, last class he said that those SpO2 monitors, even if you had one cell that's fully saturated, that it could read 100%.
I'm sure. So all it is like a little tiny beam of light. Like if you were to somehow zoom in on the process and like, I don't know, be the guy that made it, I'm sure if it's positioned correctly and you have one cell, it could give you a false reading. It's a machine. Machines are tend to fail. That's why we tell you guys like do manual blood pressures, because the thought is the automatic monitors, like when they do the blood pressure, they're using like little tiny microphones that determine like the actual sound of your heart beating, and as it's going, it does all these calculations. Where it's like if you're listening, they feel like you should be able to have a better understanding, because like what's stopping that monitor from picking up a footprint or the patient tapping on their fingers or something like that, you know? So it's kind of like a weird way to say that machines fail, but you got the gist. Then what was there? Yeah, we'll talk about this then, take a quick break. So oxygen transport, the rate of oxygen release is also increased by increased CO2 levels, decreased pH, and increased temperature. That's all I had. If you guys want to take a quick break real quick, you guys can. If not, cool. We are about third of the way through. See, it's interesting that there's so many different styles of teaching, because like when Dave teaches, it's very monotone, level sounding. It's not very engaging.
That's a style of speech, not necessarily a teaching
But
style.
he's very knowledgeable, but people tend to drift off. And then I noticed when Lisa teaches, she gets giddy and then says a lot. She gets nervous as if she doesn't know the material, even though she knows it. She's taught it many times. She gets so nervous. And then I say fuck a lot.
It's a bad review right there.
That's 1 point off your review.
I'll go home, guy. I don't care. I don't need to know this shit. Read your textbook, nerd. She's looking at me because I called her nerd, and she probably read her textbook prior to class.
I'm not answering that, she said.
You gave me crap the other day for not reading before class.
Well, it's because you gotta
And
be
I
a
ended up reading
responsible
before class.
student.
I did end up reading before that class, but I just put it off.
You were excited when I gave you that 35-page thing on end title.
Yeah, it was cool.
Oh.
Interesting. Knowledge is power.
It is. That's like when I was just starting paramedic school when I took my EMT intermediate, and then I challenged halfway through it, like they came with the A exam, so I challenged the A exam that you guys are gonna be taking. And like, all throughout paramedic school, I was like, this is cool, cause like, I was able to think at like the paramedic level, but like do things as an A, so like, I was able to be like, you're fucked up, I'm gonna call medics, that's not my job no more. I love that, great. Alright. So we're gonna talk about general pathophysiology next. So, the respiratory pathophysiology, all of this causes disruptions in ventilation. And ventilation does not equal what? What's in red? Oxygenation.
Respiration, ventilation.
Yeah, ventilation does not equal oxygenation. Ventilation is the movement of air. Oxygenation is the movement of oxygen in the tissues.
She said respiration.
Yeah, respiration is the overall action between like full lungs.
Maybe she meant cellular respiration.
No.
Do you want me to go back to the original slides? I will. I will, girl.
Look, I'm gonna argue for her against you. Ventilation is
Yeah,
a movement.
of oxygen into the body's tissues, right?
Right.
Ventilation is movement of air in and out
Does
of
not
the lungs.
equal oxygen.
Yeah, and then respiration is between the lungs and the capillary blood. So technically, oxygenation can happen without respiration.
But still, ventilation is not respiration.
Technically, you're right, but I was like, wrong.
You're not wrong.
Every other textbook and the national test is looking for respiration in response to your question, not oxygenation.
Have you seen those memes about fucking the entering key questions? It's like what I feel like this conversation is. We're arguing about the exact same thing. And then she's gonna be like, what colors are great? And they're gonna be, like, the answer's gonna be like, school bus, 17, 42, lungs. And you're gonna be like, none of those fucking work. I don't think. The lady that we had, that crazy lady, her only allergy was to purple grapes. Only purple. Really, she wasn't crazy. I would have asked her, I was like, why? Why haven't we eat a green
That's
grape?
gonna grow to be only white ones.
I would. I mean, when I was a kid, like,
The back of them, not only white ones.
I remember when I was a kid, like, I didn't know there was, like, green grapes. We'd always bought purple grapes as a kid. And I'd never gone to I didn't know where food came from either as a kid. You're like,
Deprived child.
you just always have food, right? And then I was at the grocery store and I was like, Mommy, what are those? And she was like, those are grapes. I was like, but they're green. I'm blowing. My ex's kids, she was 3 when she asked me the most racist question of my life. And this is off on a tangent. Don't put this on a review, right? So I'm fucking taking her to go get a snack. And we're at the grocery store and she sees the first African American person. She's like, why is that guy brown? I was like, that's his skin color. And I explained to her like the differences and she was like, am I black? I was like, no, I'm white. You're good. And so
You're good.
she's fine for like a few months. And then we're sitting at the dinner table one day. And dead ass, she just stops like whatever she's doing and it's just like, Mommy, if white people poop brown, do brown people poop white?
That's
I
a
was
normal
like,
question for a child.
Oh, definitely
That's
normal.
adorable.
I was like,
Definitely normal though.
it's like, no,
That's how my mind thinks.
no, that's not how it works, honey, it's cute. She was the most adorable child ever, but that's your,
But how do you know?
I mean,
I know.
she's like, I can confirm. There's- Obviously, you didn't grow up in the city and see a bunch of homeless people shit on the street.
I did not.
I feel like you're having flashbacks of like Vegas.
That's in California.
It's true. No, it's everywhere. It's literally like in any major city, you'll see like homeless people shitting on streets. Maybe not like, I don't know, does it happen in Rutland? It happens in Burlington.
I'm sure it happens in Randolph.
I'm sure it happens in Randolph.
It used to happen a lot of Randolph Ave, and the dueling seizure ladies,
Oh,
and then like the triple lesbians that lived with the Katana kid. Yeah.
Katana.
There was this fucking kid that used to just walk around Randolph with a katana. The shit you not, just like walked around unsheathed katana up and down fucking Pleasant Street.
Pleasant
Like a fucking
Street.
ninja sword.
Short.
Sword, whatever. Yeah, like a fucking, I don't know the difference, I'm not into my Asian culture studies, I don't know the difference between a katana and a samurai sword or
I'll
whatever.
just ask Jerry when I get home.
Exactly, he probably knows, he knows
There's-
cat.
There's no difference.
I'm sure there's a difference, and I'm sure I'm being ignorant for not knowing.
Holy shit. It's $1,500.
A katana?
Yeah.
No wonder he carried it everywhere.
Probably spent his entire welfare check on that guy. He lived at pretty much subsidized housing, let's be honest. But anyways, we're going off on a tangent. So, diseases that impact the upper respiratory tract reduce airflow. The upper airway trauma can cause swelling, disruption, and hemorrhage. All of that's going to impede your ability to provide oxygen to your tissues. Infection causes inflammation, abscesses, and by proxy, it's going to reduce airflow. It's going to decrease your lumen size. In COPD, we're going to talk about, I don't go into depth because we're going to beat the shit out of COPD because there's technically three different types of COPD. We're going to talk about that. Yeah, your face is just like, what the fuck?
Is it like having one of the two or both? But I thought COPD had to already have both of the conditions.
No, you can technically have COPD and just have one. COPD is like a catch-all. It's like an overclassification, and it's broken down into three categories. Technically, I'm gonna spoil it anyways, asthma technically is also considered COPD. And technically the only type of bronchitis that is COPD is chronic bronchitis, because acute bronchitis is caused by infection. We're gonna talk about that too. So disruptions in ventilation are caused by obstructions of the upper lower tract, the tongue, tissues. Sleep apnea is one of them, right? If you have sleep apnea, that makes sense. What do people use for sleep apnea?
CPAP.
And they fucking break with you every time you go on an AMS call and they have one. They're like, do I need my CPAP machine? Like, no, stop it. Whole body or aspiration, mucus accumulation, smooth muscle constriction, and edema. So, things that can also cause disruption of ventilation are disorders that affect the chest wall symmetry. So your AMP diameter should be like less than the transverse diameter, which means it should be less than like it is across, right? Make sense? So if you're barrel chested, it's closer to 1. You know what kyphosis is? It's what pregnant people get. Like they arch their back a little bit because they're carrying all that extra weight up front, so they compensate by bringing their back a little bit. And then lordosis is the opposite. That's actually, no, that's the opposite way around. Kyphosis is like when you're all fucked up this way. And lordosis is the other way. Scoliosis is what?
Curvature.
For spine.
Curvature of the spine, right? That can cause actual physical abnormalities with the chest wall development, especially if you've had it as a kid, which can cause decrease in the diameter of the chest. A pigeon chest is, I wish I had a picture for it, but it's just like when the center of your chest just kind of pokes out a little bit. And funnel chest is the opposite. And I put the actual medical terms for all you people that actually like that. Hectus perineum, I don't know, and pectus excavatum. I don't speak Latin, so I don't know. Chest wall trauma, pneumothorax, hemothorax, flail chest, diaphragmatic issues, rupture, paralysis, neuromuscular disease like ALS and multiple sclerosis, all of those can cause diaphragmatic issues, because that causes like nerve damage, which inevitably decrease the ability for the diaphragm to work. And then overall nervous system diseases, cancer, CVA, diabetes. If you take CNS depressants or stimulants, like one of those could be morphine, as I talked about. Morphine causes chest wall rigidity. Technically, that would be respiratory pathophysiology, because it's a disease pathway of some sort. Increased intracranial pressure, because that's going to skew the body's ability to regulate its own like chemoreceptors, right? And then trauma or surgery. Cracked your knuckles, and then it made me have to. Okay. Disruption in perfusion. Adequate blood volume is needed for everything for life, right? So if you don't have enough blood volume, you're going to have a decrease in perfusion. That's going to be caused by disease, AMI, which is what?
Myocardial infarction.
Yeah, trauma, PE. So I did what I told you guys never to do, and I talked about documentation at one point. You don't know if that's pulmonary edema or pulmonary embolism, or physical examination, or what the fuck else, or physical education, gym class. You don't know, right? Shock, hypovolemia, hemorrhage, dehydration, disability of blood to transport oxygen, i.e. disability when it's used in medicine is like it's not like disability like we think of like mental handicaps or like can't use their legs. It's just like a impairment of the body to do something. So anemia, sickle cell, and CO poisoning. So we're going to talk about the evaluation and assessment of these procedures. All of these are going to be, we're not going to specifically talk about any specific diseases yet. This just be generalized assessment, so it's going to be a catch-all. So after we talk about this, we'll go into the specific disorders, and I made sure, I put a slide in there that says pre-hospital treatment. It might not be related to your book. I used it directly from our protocols, so it might be important for you guys to actually pay attention to those slides, because like, that'll help you guys actually learn how to treat patients, because I feel like you guys will understand textbook medicine by the time you guys get done here, but like, I'm trying to make you guys good providers, not textbook providers. So, respiratory problems exist in varying degrees, and I did copy the book's chart in a moment. So mild dyspnea is like just like your general shortness of breath, right? Cool, I can't breathe. Severe dyspnea is like, cool, you can't speak, you're tripoding, maybe you're having some wheezing, coughing, you might notice some accessory muscle usage. Hypoxia and exhaustion, you'll start seeing the cyanosis, ultramental status, weak respiratory effort leading to respiratory failure, and then obviously respiratory arrest. Pretty much everything, if you hear the word arrest in it, you can tell it's kind of going to be bad. Cardiac arrest, respiratory arrest, ineffective respiratory effort or apnea. And fun fact is, do you guys remember the term for normal respirations? I mentioned it when I taught medical terminology. Eupnea. E-U-P-N-E-A. Eupnea. So, alright, moving on. I thought it was cool. So, I'm also learned. Guys haven't gathered. So, respiratory rates. Normal. So, 12 to 20 beats per minute, right? Or not beats per minute, but breaths per minute. We all know that. Respiratory distress, that may be normal, but it's probably going to be some sort of outside of the realm. It could be lower than 12, it could be higher than 20. That kind of just depends on what's going on. Respiratory failure, you're typically looking at 8 or less, or greater than 30. And respiratory arrest is either agonal, which are what type of respirations?
Irregular gasping.
Perfect. Yep. Or absent. Those are also called ataxic respirations. So total volume. In a normal patient, we know it's free movement of air. It's going to have adequate depth. You're smiling. Was it fun? Saved a life.
You didn't hear the yo-yo job that we just done? Sent out to Route 12 for the accident, then can you divert to the barracks for the
Yeah,
drug?
we heard. So, you're gonna have adequate tidal volume, so that's, what's that inside the normal adult? 500, right? So respiratory distress, it might be increased, decreased. If you're increasing respirations, you're gonna have probably shallower respirations, but if you're slower, you might be taking deeper breaths, which might give you more tidal volume. Respiratory failure, you're gonna have complete inadequate respirations, and that's where you're gonna wanna intervene. Over 30, you're not breathing effectively. Under 8, you should be probably looking at maybe over 30. Why'd you look confused?
What? You just leave?
Oh,
They've got a Dartmouth run.
oh, is that what it is?
Yeah, he's gonna call.
I just realized his bag was gone.
Oh. I didn't, I thought he just got to go to the bathroom or something.
Yeah, no, me too, and then I realized his bag was gone. I was really confused.
It just happened to be as I said it, your face was just like, I was like, did I say something confusing? I thought that made sense, but, okay, moving on. Respiratory failure, you have the inadequate respirations, like that's where you're gonna need to step up now. The respiratory arrest, obviously, there was minimal to no tidal volume, because they're probably not breathing. Breath sounds in a normal patient, they might be abnormal breath sounds, and you're gonna have sounds equal in all fields. This is like the healthy adult, cool, no problems. Mild respiratory distress, you might have stridor, which is indicative of what type of airway obstruction? Upper airway obstruction. Wheezing, which is caused by what? We're gonna talk about all this. Bronchoconstriction, bronchi, and crackles. What is bronchi caused by, Jackson?
I don't know.
Fluid. That's the body trying to,
Lower.
the air trying to go through fluid. Crackles. And sometimes you might have your breath sounds that are gonna be diminished or unequal on either side. Respiratory failure, you might have the exact same thing, so that's fucking cool. And then absent for respiratory arrest. So all of this is just meant to tell you that if you see these signs, you should start thinking, okay, so normal breathing, respiratory distress, respiratory failure. And you should really, I was hoping that this chart, I copied this verbatim from your textbook. I was hoping that this would classify it as, because at the ACLS and PALS and PEP, all these other like alphabet soup courses you can take, they actually break it down into mild, severe, and moderate respiratory distress, which tell you like, okay, based off these findings, you should be more concerned this patient's going to imminent failure. So I would say if you see a patient that's what they call the, I never had that on the side, I was on this one. If you see a patient about right here, which is severe dyspnea, like I had put here, this is probably realistically right on this line of respiratory distress and respiratory failure. That's when you're using those accessory muscles, your tripoding. That's your body's like last ditch effort of like, what can I do to get more air inside the lungs? And if you're at that point, you should start thinking like, okay, maybe I have to stop fucking smiling. It's like, you're creeping me out, man.
That's my fault, sorry.
I hate all of you guys judging me, your looks. Now I lost my train of thought,
So-
thanks guys.
Josh, the accessory muscle use, intercostal use and all that, is that a compensating sign or is it a decompensating?
Well, it's a compensating or decompensating sign, because like, you're using muscles to compensate for the lack of oxygen. So it's kind of both, like, for different reasons. Your body is trying to compensate for the lack of blood flow or inability to get more air in, so it uses those muscles. So from the patient side, it's a compensatory mechanism. For us, it's a decompensatory mechanism, because we use that as like a, oh shit, they're actually like having severe problems. So both, if that makes sense, but for different reasons.
I have a stupid question.
No such thing.
Can you go back? So I had a patient with my paramedic the other day that was like on the line between respiratory distress and respiratory failure, but leaning more towards failure. But she wouldn't let us like put on the CPAP or anything. Like she like would like she was like going unresponsive, but like slapping it out of her hands, slapping it away from her face and everything. So like in that situation, do you just like wait for them to go unresponsive, or like what do you do?
At your level, yes. That's exactly what I would do. I would say, if she would allow you to put like the bag on, like the actual BVM mask on her,
She didn't.
Or
Oh,
if she
she
would,
would
or if you
wasn't
could like do blow by, or maybe hand it to her and have her try to put it on her face, that's what I would do. But if she's not gonna let you do anything, you can't like, be like, bitch, take this CPAP, right?
Yeah.
That's like why I love when like you go to like the 16-year-old girl having a panic attack at the grocery store, and she doesn't wanna listen to you. I love it, just, the body's gonna eventually fix itself, right? It's gonna eventually pass out, go unresponsive, and then you can not CPAP her, but you'll be able to BVM her, which is the same thing.
Mhm.
Yes and no. In principle, it does the same thing. Or if she's like super tachycardic, or not tachycardic, tachypnic, and she's breathing really quickly, and she's throwing off her fucking carbon dioxide levels because she's amped up, the body is eventually just gonna be like, you know what, I'm done. She's gonna pass out real quick, it's gonna reset all those mechanisms, then she'll be fine. So, I would say for you guys, it's like, yeah, if she doesn't wanna listen to you, just let her pass out. Go unresponsive, because you can fix that, right? She doesn't responsive, now you get to do cool shit. Now you get to like, put a fucking definitive airway in her, bag her. I mean, if she's unresponsive, I'm dropping it too, because that's like, that's pretty cool, why not? There's like kind of a coolness factor to everything we do. And you know, like, that's why we're messed up, because like, all the good calls are the shitty ones you did like 8,000 skills on. Like, do you think Jackson remember the car accident we went to that we didn't do anything, or the car accident where the dude got fucked up and I let him drill him with an IO? Like, he's gonna remember the IO call.
Still waiting for that one.
He's gonna be like, I drilled that chick. Ugh. Probably should have used a girl. I realized how sexist that sounded. This is why they hand out reviews tonight. So, normal patient appearance. You're probably gonna have good skin color for normal breathing. As they become as they get into that respiratory distress, they become anxious, right? As we talked about, when they become stressed, you're gonna become tachycardic, tachypnic, you're gonna start compensating for the fact that you don't have enough oxygen, or you perceive that you don't have enough oxygen. Because a lot of this is like, kind of psychosomatic, right? At some level, your body is like, cool, I think I'm dying. I need to breathe faster and freak out. When like, really, you're not dying, you'll be fine. But respiratory failure patients, they are anxious because they actually are dying. And they might become cyanotic, they might have a decreased level of responsiveness, they might become confused, and that's super important. The alto mental status in a shortness of breath patient indicates severe hypoxia, which means it's definitely not just like a mechanical ventilation problem, it's like definitely an oxygenation problem as well. In respiratory distress or arrest, you're gonna have decreased confidence, and they're gonna be cyanotic or pale or I don't know, whatever color you wanna call them, like dead pretty much. So, necessary interventions. I use the actual answer. I think your textbook says 95% for oxygen saturation. I had never fucking heard that. It was always 94. I don't know when they changed it. So I put 94 on my PowerPoint slide, so if it's 95, sue me. I always thought 94, and that's what protocol still states, and that's what the rest of the fucking world still uses. Except for like hypertension, that got lowered to like, if you have 130 systolic, you know, hypertensive. Blows my mind. Anyways. What was that? No, it's not like you're hypertensive if you have like a blood pressure of like 130s or 135.
Well, back in the EMT class, I remember you specifically saying the whole world lives hypertensive, because 120 is actually slightly high. We're aiming for 100 ideally, so
Yeah, I mean, that's
it's a
why, like,
totally logical reason for changing it,
if you're
based
Terry-
on what you said.
If you're Terry Crews, you have a resting heart rate of like 6, so.
Hey. It's all the yogurt he eats.
Dude, he has the most healthy GI tract in the world. All those probiotics. So respiratory failures, we're gonna wanna assist with those ventilations. CPAP, BiPAP, BVM. I put BiPAP on there because although you guys can't use BiPAP, BiPAP is like CPAP, but it helps with inspiratory and expiratory pressures, whereas CPAP only is on inspiratory pressure, right? And BiPAP is like not even a paramedic level skill, that's a critical care skill. If not like a respiratory therapist, nurse anesthetist type skill. That's what they're gonna use in the hospitals. And if they're respiratory arrest, you should just be bagging them. If you're not, you're wrong. So, learn to start on inspecting your patients physically. So, start off, everything comes down to skin, right? Skin is the number one chief determinator, because you should be able to see this across the room, on someone's ability to be, on their level of perfusion and oxygenation, right? So skin color, that's why we teach you guys color, temperature, condition. Nails. So if you have clubbing in the fingertips, that's important for some disease pathologies. So if you see a patient with clubbed fingers, you should be thinking like, okay, they have a chronic respiratory disorder. It's actually COPD, but we're gonna talk about which one. And you might see underneath the fingernail bed is where we check cap refill. That's where you're gonna see on like your thin mucosal membranes, lips, eyelids, your fingernail beds. This you're gonna see cyanosis first, right? Then position, tripoding, full foulers. Who's on a call with me? Did me and you take that lady with like the I have autism dog tags?
Yes,
Yeah,
yes.
do you remember how we walked into her bedroom and she had like 8 billion pillows?
Yeah,
And I even asked her, I was like, God, you have a lot of pillows.
yeah.
So that's full foulers, right? That means like, in addition to her sleep apnea, she needs to sit like this to sleep. Like, that's important, right? Because that means like, okay, so you don't want to be sitting down. Positional comfort plays into your ability to treat and assess. Respirations, your rate, bradypnea, tachypnea, apnea, all of those are super important, right? Too slow, too fast, not breathing. The rhythm, is it regular or irregular? Does their chest rise, fall in a cyclical pattern, up, down, or is it up, down, up, down, up, down, up, down, up, down? Up, down, up, down, up, down. That's actually, we're gonna talk about respiratory patterns, but that's important, cause like, certain respiratory patterns are gonna lead you to different clinical manifestations on what's causing that. Speaking of full sentences, how many words? Does it improve? What the fuck do
I
y'all
just
keep-
had the office kind of run through my mind. Yeah.
Like a peanut gallery back there.
My bad.
I don't care. This cracks me up. So speaking of full sentences, how many words improve your otherwise? Now I track what you mean. Why use little words or big words when little words effective? Damn it. I hate you. I've seen The Office in its entirety like 6 times. It's stupid. But yeah, that's a good thing. If they're speaking, if you remember that case study at the very beginning, right? The person was talking in maybe 2 to 3 word sentences at a time. Does that get better? Has it gotten worse? Was he speaking in full sentences and now he's not speaking in full sentences? All of that's kind of important. So the 2 big patterns of breathing I want to talk about today are Shane-Stokes and Kussmaul's. So Shane-Stokes is deep, rapid respirations with a crescendo, diminuendo pattern. It means it gets really, really big, and then it fucking goes apneic for a period of time, right? That's why those things are on there. So this is what you're gonna see in a lot of like neurological trauma patients, or CHF will cause this as well, newborns, and if you have like high altitude sickness, you'll also see Shane-Stokes respiration. Not all the time, but like, you also see it in like, if someone has decompression sickness, they go from like a pressurized environment to a really high environment in terms of pressure, even though it was negative. You can also have that. Whereas Kussmaul's is that deep, rapid respirations. And why, and you're gonna see this in a lot in specifically diabetic ketoacidosis and renal failure. It's not as often, but you'll sometimes see it. But why does Kussmaul's have deep, rapid respirations?
Trying to off-gas CO2.
Yeah, but why? Like the two things, the metabolic acidosis and diabetes, right, and renal failure, but why is it trying to get rid of the CO2?
Because there's a buildup of it and you've gone acidic.
No, so actually it is, yes, you're on the right track, but not quite what I'm asking for. So it's getting rid of the CO2 not because it needs to, but because there's other things in the blood that are making you more acidic. And so the best way to treat metabolic acidosis is to off-vent all that CO2, because that's the number one thing your body can do, right? So that, I remember Lisa talked about it, so I remember Alexa actually talking to me about it on shift. You can have a difference between metabolic acidosis and alkalosis and you can be in like metabolic acidosis, but respiratory alkalosis. So it's like a weird fucking pH thing. We're not gonna get into that, but, so, just understand that like why Kussmaul's is happening in DKA is to try to correct the body's excessive metabolites, right? And the best way to do that is to get rid of CO2. DKA, when you guys talk about it, if you guys have, I don't know if you guys have or not, it's a serious problem, needs to be treated. And it's, you're gonna usually see it in like, when you go to the diabetic and it just says high on your glucometer, that's like usually where it's at, is DKA land.
So, so for the DKA patient, you're saying the body is off-gassing the CO2 to compensate for the other things that are causing
Yeah,
acidosis?
so it's metabolic acidosis, which is caused, which is one of the byproducts of being in DKA.
Yep.
And it gets really complicated, cause like, it's all about ketones. Ketones also produce like acetone and a bunch of other weird things that, that's for like your endocrine lecture, and I believe it'll be an endocrine or toxicology, I think I also might be teaching toxicology. But yeah, so the best way to counteract that is to get rid of the quickest thing, cause like, if you don't have to pee right now, you're not gonna be able to excrete things to the kidneys and the urine, right? So what's the best thing your body can get rid of? CO2, and that's why it goes through that. But you also can't survive without CO2 because like that's what drives you to breathe. So, which is why Kussmaul's is kind of a big deal. And I guess while we're sidetracked a little bit, what can we do for DKA outside of like bagging these patients to fix the respiratory pattern? Huh? Yeah. And that's something you're never gonna be able to give enough fluid in, Rob. That's like the patient you're just gonna drop liters in, because why not? And it's just, that's what they're gonna need, and in the hospital, they'll receive insulin, and they'll actually get more fluid. But for us, all we can do at any provider level is just fluid.
So medics can't do insulin?
No. Nope, we don't carry insulin.
So people at home can do insulin on their own?
Yep, just like EMTs can give, you guys all in this room can give nitroglycerin without an IV. Once you become an AEMT, fuck that, can no longer assist with nitro without an IV line. You have to have an IV before you give nitro. So, you have like a weird restriction now, so.
It's probably gonna be a stupid question. If
No
the
such
body-
thing as stupid questions, damn. That's not just
If the body's trying to fix the fact that it's acidotic, wouldn't it be more effective for the body just to throw up to get rid of some of the hydrochloric acid in the stomach?
So hydrochloric acid is produced in response to having a full stomach, right? So think about like the very basics of having respiratory distress, right? It's a stressful problem, right? What nervous system is stimulated during stress? Sympathetic, right? And the sympathetic causes decreased gastric motility and shuts down your body's GI tract as well. So like, you're not gonna really be producing hydrochloric acid. In fact, it'll stop it, and it'll actually stop digestion. So,
So it's already doing something in that regard.
and.
Well, and isn't it also that, yeah, I mean, if you throw up acid that's in your stomach, that acid's not in your blood, so it's not really
Yeah,
gonna
it's
do
not being
anything for your
diffused, cause
blood
like
level.
it's all contained, so like it's not doing anything, it's not affecting your blood pH. So, but that's not a terrible idea, just like, I'll tell you guys like a folly of mine, so you all know what epistaxis is, right? And you guys just took your epinephrine lecture. Our paramedic instructor, like, I don't know, 6 years ago or some shit, he asked us all, what are some creative uses for meds that we learned in class? Or can you think of any fringe uses for any of the medications you learned? And bear in mind, we get taught like 50, 60 different medications. I was like, fuck it, let's just start giving epi to people with nosebleeds. And he was like, what the fuck? Why? And I was like, well, it's a vasoconstrictor, it'll fucking stop the bleed, it'll tamp on it. He was like, you're an idiot. I was like, no, that's why they use like the fucking nasal sprays. Nasal sprays cause vasoconstriction. Why not just use like epi-nasal sprays? He was like,
Wouldn't it also increase the blood pressure though, which would just
I
cause the
didn't
blood
care
to be
about
worse?
that. I just cared about stopping the nosebleed. I didn't think about any of the side effects.
But it would increase the nosebleed.
it would technically, because it's small vessels, I feel like it would cause vasoconstriction to shut off those vessels.
If the constriction is greater than the blood pressure increase. Right?
Can we try it?
I mean, I'm down.
Go get an atomizer.
Yeah, let's do it. But then
What?
that phrase is which concentration do you use? 1 to 1 or 1 to 10?
Probably 1
We
to
can
10.
try both. You got 2 nostrils.
I'm not doing this. I gotta be there when you guys go into cardiac arrest from like the amount of epi we're administering nasally. Plus, I don't think you can even see. I feel like I don't know. The thought was there, and he was like, "That's the most creative use of epi I've ever heard," but you're wrong. I was like,
I
"Okay."
asked my teacher if we could use it, if, you could use it to get into, whatever it's called, anaerobic respiration. Because you're increasing your heart rate.
You probably would eventually get there.
No, like if you would inject epi and then go work out, apparently that was a really dumb idea.
Well, not. I mean, it's not a total dumb idea. It does.
She said it would stimulate the sympathetic nervous system, which then has reactions to store fat instead of burn fat.
Yeah, I mean, it'll do what pre-workout does. That's why I think pre-workout fundamentally for like going, you don't pop pre-workout and then go for a fucking run. That's stupid, right? People go to a pre-workout when they go to lift weights because they're not going to achieve the higher heart rate that they need to. I mean, I don't even understand. Are they like curling like 15 pounds? Like, has anyone gone to the gym, lifted weights, and like got their heart rate going? I don't understand people that need to take pre-workout to go lift weights, as if like that's not going to help you achieve like your cardiac thresholds. But we're on a tangent here. Sorry. So respiration's depth. Is it deep versus shallow? Deep, you're increasing the tidal volume, probably indicative of some sort of respiratory distress. If it's shallow, you're not getting enough air, so it means you might cause hypoxia. And worker breathing, is it labored versus unlabored? So if you're labored, you're going to have retractions, and there's different spots you can look at retractions. Supraclavicular, so above the clavicle, right? So suprasternal, so above the sternum. You might see it like right at like the, I think this is called the angle of Louis, if I remember correctly, right? The intercostal retractions and subcostal subcostal retractions. All of those are super easy to see, but you will rarely see these two, intercostal and subcostal retraction, because most people don't expose. Most people don't like, hey, you're having trouble breathing, take your shirt off. Like, it's not my first goal, but you should be able to see if you're doing an EKG on these people, because if you guys took my EMT class, you know that I say you do an EKG for everything, because I teach the EMT level cardiology as well. And you should be able to, like, when you're pulling down, put your fucking stickers on their chest or on their shoulders, you should be able to see those retractions. You might not see super sternal, but depends on what they're wearing. You'll see it a lot more in female patients because they tend to wear more revealing shirts than men do. Labor breathing, you're also going to see nasal flaring, accessory muscle usage. That's where you're also going to see your tripoding and your head bobbing. Head bobbing is like the whole like, it's like that drunken fucking bob. You see a lot in children, especially if they have like pediatric respiratory distress problems. And fun fact, kids, number one reason they go into cardiac arrest is due to respiratory problems. So that's why, like, you just breathe for a kid that they're not, instead of doing CPR, that usually works. Chest excursion. So that's a fancy way of saying rise and fall of the chest. It is repeated throughout the rest of those lectures, so that's what I call it. So is it symmetrical or is it flail? Or is it paradoxical? I didn't even think of that when I made this lecture yesterday. What is paradoxical movement?
Opposite.
So, yes, but also more specifically, you'll see it like when they take a deep breath, it like sucks in completely. Like it might not move at all. So palpation. There's one thing I didn't mention here, and I don't know if your book mentioned it. Since you did a reading,
Oh, so sorry.
did the book mention fremitus at all? Perfect, because I didn't put it in there.
That was good.
I think it's a crack of shit. That's my personal feeling about it, so that's why I put it in. Alright, so you wanna palpate for any tenderness of the chest, if they're massive, it doesn't feel symmetrical. That's why when we do our trauma assessment, we feel both sides of the ribcage, have you take a deep breath, because we wanna be able to feel the symmetry. What are you doing, Jackson?
I sneezed on him.
Okay.
Dude, you're fine.
Tracheal deviation versus midline. If you have a patient, you shouldn't just look for tracheal deviation, you should be able to feel, because you might be able to feel minor deviation that you might not be able to see. Because remember, like, there's a lot of shit going on in the neck area, right? Especially if your patient's C-collar, you're gonna have to palpate for that tracheal deviation rather than just visually inspecting, because that little tiny window thing is super unreliable. Crepitus is a cracking sensation. It's usually caused by bony injuries, or you can have it by subcutaneous emphysema, which is just like air trapped underneath the fucking skin, and it's really cool. It feels like popcorn on their skin. I don't know if you guys have ever seen it. Have any of you guys seen it?
I kind of saw it like one time. It was like the beginning of it, so it wasn't bad. But like my paramedic was like, "Hey, come poke this," and I was like, "Oh, that's fucking."
Yeah, it's gross. First time I ever saw it, and the only time I've ever seen it, was in my 2 weeks on the Loyal ambulance. So that was fucking cool. So you want to compare all areas bilaterally. So apex, apex, base, base, right? You took my EMT class, you know I said that shit all the time. That's because if you do up, down, by the time you get to the next up, you don't know what the other up sounds like. You want to check for resonance, which is just the sound it makes, right? So it should be normal in all fields, so just normal resonance. It's just, I don't know how to describe normal resonance. Hyperresonance is it makes too much noise. It's usually a sign that it's overinflated. That's caused by emphysema, pneumothorax, asthma, conditions that cause air to be trapped inside the lungs. Dullness, like if you're tapping on someone's clothing or something, that's caused by consolidation of like lung tissue or just decreasing or like lack of air inside there. Pneumonia, atelectasis, which is like breakdown of like a complete collapse of a lung lobe. Pleural effusion, which is what? Any of you guys know what's happening? So pleural effusion is like when the pleura, right, gets filled up with fluid. And pneumothorax. So upper airway, on auscultation, you're going to hear stridor, you might hear hoarseness, muffled voice. Your book called it hot voice or potato voice or some shit. I don't remember what it was there.
Heard it described underwater.
What?
I've heard people describe it like hearing underwater.
Sure. I've never heard of a muffled voice. I've never seen it. I don't even know what to begin to sound. What it would begin to sound like. We are going to hear lung sounds, hopefully. And hopefully this thing is loud enough that you guys will be able to hear it. Probably. Okay. So, vesicular sounds are normal lung sounds. They're pretty low pitched. There's technically 2 types, but for your purposes, you're just hearing all of them. So, the lung sounds you're going to be hearing are technically bronchovesicular. That's all I can find. And those are usually heard over major bronchi. It's a little bit louder than vesicular sounds. And bronchial sounds are actually heard if you like put your stethoscope diaphragm directly on the trachea. I do this all the time for my difficulty breathing patients because you actually want to hear like tracheal sounds too, because that shows good airflow in and out without any obstruction. If you have like a mucus plug or something blocking the trachea, it could like decrease amount of air. So let's see if you can hear it. No? Maybe not. You guys hear this? If not, come gather around. Here. Hear back there? So. Or just have to keep it plugged in this zone, it might get fucked up, so I apologize. So this is showing like where the sounds are heard. So adventitious sounds are any sounds that are abnormal. That's the actual term for them. But usually we just say they're not normal run sounds, or they say abnormal lung sounds. But the correct term is adventitious, per textbook. Those are crackles and rails. They're actually the same thing. I mean, it's not 100%, but they're used interchangeably for a lot of disorders. You might hear it's called crackles or rails or both, but essentially they're talking about the exact same thing. Rhonchi, wheezes, and friction rubs. Friction rubs, I do not have a sound of, but we will talk about very briefly. I believe if not, I'll talk about it. So crackles and rails are heard more on inspiration. They're discrete, short, they're high-pitched, they're sonorous. It's due to lack of compliance with the lung tissue itself, right? It kind of feels like literally someone crackling paper, which is why they're called crackles. I'm gonna wait for that tone because you guys won't be able to hear fucking lung sounds too. That. What if not? Yeah, you want to hear. Okay, that was not again. All of these are real lung sounds taken from like a patient at UVM. Can you guys hear that? You might need to come up here, guy, because like your fucking hearing is awful. I know that about you. So there's two types of crackles. We're just going to talk about it. I'm not going to put it up on there. There's fine and coarse. Okay, fine crackles originate in small airways, so your bronchioles, and your coarse crackles originate in like the larger airways, so your main subbronchus, etc. Then you have bronchi. Bronchi is that deep rumbling sound. It can clear or change if you cough. And it kind of sounds like air moving through either thick secretions or mucus, or even if there's like a fluid, be it like serous fluid, blood, stuff like that inside the lungs, you can get bronchi. And it sounds like this. Cool.
That's inhalation, right?
That's
Or kind of cool.
It was both.
yeah, that's not insulation. So that's actually worse. This particular lung sound is worse. But yeah, usually you hear more on expiration, but at least in my experience, like I've mostly heard on expiration, but. So wheezes, we all heard those before, you're still gonna hear it again. Those are signs of airway constriction, typically lower airway obstruction. It's a high-pitched whistling sound. It's just air moving through a narrow passage. You see it a lot in what sort of diseases? Asthma, you might see it in allergies. Not so much like stridorous sounds from like an airway compromise, or like airway shutting off, but like you might hear it if someone has seasonal allergies. It's super faint. And then you can actually hear the severity of the airway obstruction based off the level of wheezes they have. So typically wheezes are expiratory, but if you have inspiratory wheezes, that means that it's a little bit more severe than just expiratory wheezes. And then you can have end expiratory wheezes. So whenever you breathe, you take a deep breath. Your body tries to puff out that little extra. Very end, there's a brief pause before you inhale again. And if you get a wheeze at the end of the exhalation phase, that's like kind of severe level of bronchoconstriction. If you can hear an expiratory wheezes on a Belgian, I will fucking buy you whatever you want. I'm not really, I'll buy you like a coffee or something. Cool. That's all of the sounds, so it's your high-speed fucking PowerPoint technology that didn't work. After patient assessment, we'll take another break and then we'll move on from there. So, the only difference, really, that I kind of want to touch upon is infants. They're a little bit more barrel-chested, they're obligate nose breathers, which means they primarily breathe from their nose. So, they haven't learned how to breathe through their mouth, so you can actually like just pinch baby's nose and that's why they start freaking out because they don't know how to breathe throughout their mouth. The respiratory rates are a little bit higher in newborns by a lot, 30 to 80. Why are you like smiling? Are you just imagining me like walking up to an infant and like plugging its nose?
I
and,
could
like-
totally imagine you doing that. That's what's scary.
That's what I mean. You're just sitting there with like a devious grin. I don't just go suffocate babies by like plugging their nose. 20 to 40 at 1 year old and 20 to 30 at 3 years old. And you can see the older you get, they start normalizing on the vital signs that we're very accustomed to. And they grunt a lot, and that's just like part of a compensatory mechanism that they do. You just deal with it, they grunt. It's weird. So certain medications are gonna affect all sorts of things. I'm not gonna go through all of these, but just be aware that the following medications lead you to believe that there was something going on respiratory-wise, right? And this is part of your assessment, so in determining if they're having respiratory emergency. If they're on antibiotics, NSAIDs, anti-inflammatories, mast cell stabilizers versus leukotriene inhibitors, bronchodilators, either the short or the long-term acting beta adrenergic agonists, anticholinergic beta or bronchodilators, xanthine bronchodilators, antitussives or cough suppressants, expectorants, mucolytics, pancreatic enzymes, or if they're on oxygen. I'm not going to go through examples on how it works, but if you'd like, I can send you this PowerPoint afterwards so you can review it yourself. So we're going to take a quick break real quick. About halfway done. Man, I really want that Ben and Jerry's.
Take both bites.
I don't need my dinner yet. Well, I had a piece of chicken.
I was gonna say,
I was getting a piece of chicken.
we can have like.
Swear to God, if you steal my Ben and Jerry's, I will literally cut you. Fucking end his existence. I'll hit the bay next time we work together with the truck and blame it on him. Have Mike freak out.
Every time someone hits the bay, they're like, did you hit the bay? I'm like, I've never hit anything.
Paul Wenham took out the side of the left side of the bay.
I lightly back into our side of the truck. It was very light. Linda didn't even realize it happened. She was right next to me, so we're good. I felt it, and I looked over, and she was still just looking forward, looking. I was like, okay, we're good, we're good. Just pull forward. I would let her walk into the meeting area, and I pulled the light forward, back on the truck.
So,
Piece of shit, we're selling it anyway.
I'm giving you a mission. Your goal is to change Linda's perception of me as a provider. She thinks I'm an asshole, and I don't understand why. I've never done anything to her. Like, at all.
I can do that.
You know, I got the employee review email,
Which one?
the one from Matt, who
Yeah.
would fill out this employee review, like, what would you like to change or what? I considered,
Oh, I
like,
totally forgot about
I
that.
haven't done it yet.
You still do it.
I considered in the comment section to be like, people think Josh is mean, Josh is actually nice.
We should do it.
Here are people who are mean.
I would do that. I've said that so there's 3 questions on it. One is,
Do you think Matt's doing a good job?
yeah, I said no. No, it's not, is he doing a good job, it's he made a positive impact.
Oh.
I said no because there's no other option. I want an option that says,
No, you even specified at the bottom.
yeah, at the bottom, that's other, like what can you firm do to improve?
No,
I don't
no,
think
like
you-
right after the 1 and 2 question, there's like a little box.
It was
Just so you
not,
haven't
not
taken
for Matt's section. Oh, actually, yeah, there is, but there's no like third bubble option.
But you can like.
I don't think he's done anything, he hasn't changed anything, that's the point of why he was like such a great pick. He said, I don't wanna change things, I just wanna keep things going the way they are to minimize employee impact. So he hasn't had a positive or negative impact, I want like, is there like a middle option, like?
Isn't the not saying no to any transfers a Matt thing?
Yeah, no, that's a board thing, not a Matt thing.
Hmm.
But,
I ran into some random guy at the post office in Bethel because he and this other old lady were walking down the stairs in front of me and they just
You're very
stopped.
descriptive.
They stopped mid-stair, like, and said nothing, and I was like behind them. I was like, do I say, excuse me, like, do they know I'm back here? A couple seconds go by, they finally move, he gets down to the bottom, he's like, are you a teacher? I'm like, no, I'm not. He's like, where do you work? I'm like, well, I have 2 jobs. He's like, well, what do you do? I'm like, well,
I'm a waitress and an EMT, I
Waitress
save
and
lives
an
and
No, I get
serve
that.
you food.
and he's
I'm
like,
a waiter in EMT.
and he's like, where are you in EMT? I'm like, right, River Valley. And he's like, oh, I'm on the board, blah, blah, blah. And he like went on for like 30 minutes. But he was like, you're gonna do great there, blah, blah, blah. And I'm like, I don't, okay, thank you.
But, yeah, he, like, I felt bad, I wish there was another option, cause like, I don't think he's doing a good or a bad job, I think it's just,
I feel
indifferent.
like by saying no, it's more bad job than,
Maybe, I told him to his face, I was like, I put no because there was no middle option, and he was like, he didn't say anything. I was like, I don't think you're doing a bad job, none of them applied. And
is
then,
that, and I also wanna know, like, is that survey read by him or is that like the board thing?
oh, he's reading them, but it's anonymous, so you can't tell who submitted what.
That's what they, so we have to do,
I mean, I guess like if he was,
employee opinion surveys, but like you have to, it's anonymous, but you have to put like your job title, how long you've worked there, and that's like.
yeah,
like,
ours doesn't have that.
And that says all, but like, you don't put your name, you put every other descriptive feature you have, and they can easily narrow it down.
Every time I go to start writing the bottom thing, I realize like it keeps narrowing in whenever I write anything. So it's
Like,
like,
you're the one that probably writes stuff, so.
I'm also a newbie, so like,
Well, so I threw it off, like on my comment, I mentioned stuff about per diems, because like, as a full-timer, they would be like, no, a full-timer gives a fuck about per diem hours. So I threw off the scent by, so they can't target if I talk about per diem hours.
well, you're probably the only one who said no.
No, I'm probably not, honestly. I put like super bad opinions about like the very first option, I think I put like at poor, cause like I feel like morale's at an all-time low for Brooklyn, personally, but.
I'm my only EMT job, I don't have anything to compare it to.
Well, also, I've been here for like 4 fucking years, 4 or 5
Yeah,
years, so.
but like that's why like my opinion is like,
It's still valued, don't say it's not.
no,
Your
it's just, it's very obvious.
But it's, no, not really. It's different, and that's the point. It's like, how do you feel going into this agency? Like, did you wanna work here to do BLS transfers from Brattleboro to Springfield, Mass? Or did you wanna work here to like, get back to your community and run 911 calls?
Yeah.
And that's where we used to be focused on, and like, we're not anymore, and I personally don't like that.
Well, if we're gonna.
Cause the
look
town's
at-
paying us to provide 911 coverage for these towns, but we're going on so many fucking transfers that like,
Aren't you not allowed to get at least one 911 truck in service?
oh, we do.
Yeah.
We still do that, we don't, the only time we don't, and this is like always been our policy and our board knows it, if Gifford has a STEMI or like an emergent transfer, we treat that as a
But yeah,
911.
that's basically a 911.
Yeah, and that,
Apparently, we had 2 STEMIs in a week, a couple weeks ago.
but like, outside of that, we always leave one truck in service, but a good example is, the other day, we took a paramedic transfer from Brattleboro Memorial Hospital to Springfield, Mass. For a patient that was on blood. So it's 2 hours, 3 hours away to get there. We drive there, the patient is now no longer a paramedic level transfer, he's now no
Yeah, he
longer
was-
on blood,
Was it last Thursday, when we were in class and you were texting Crystal about it?
yes. Yeah, no longer a paramedic level call. Like even the doctor was like, oh yeah, he doesn't need cardiac monitor anymore. I was like, I'm gonna keep it on, I guess, cause we're there. And like, we had to call in other paramedics to cover the shift, cause I was the only medic on. And so like, now you're doing overtime. Did you fucking eat my ice cream?
No, I didn't eat your ice cream, Josh.
Like, so now we gotta pay overtime, and like, then on top of that, we use up the entire tank of fuel on that call.
We used the
and-
entire tank, like we topped it off right before we got back and it was like on the red on E.
And then on top of that, like, they also bought us dinner, right? So,
I did
like,
not.
It's cause you forgot the card. So, like, I don't know, I feel like at that point, we drove like 3/4, probably 75% longer without a patient than we did with a patient. Like, how is that worth it financially? And then the argument, the counter argument to that is, well, we're paying you to be here anyways, might as well make some money. I get that, but.
I mean, there's a point where you're making money, and there's a point where you're detracting from the service.
And I just feel like that causes provider fatigue and decreases morale, cause like, I don't wanna,
Also, what if you were to give back, you just barely feel up and do a STEMI, and like, I guess that's not a true,
What-
like,
well, no, so like my.
like you
crew-
get a code, like you have to go and work it after you just drove for 4 hours.
Any of my partners know, if we go on a transfer and there's any 911 call, I'm up next. So I can go on this 6-hour transfer, and if, I'm not gonna say the name of the supervisor that's on shift, but if he leaves the station and does a no transport, I can get back from the 6-hour call and I have to take the next 911 call too. Like, that's,
Which we did have to go on when like 2 hours after we got back, or
yeah,
for a few.
which, whatever, I understand that happens, and like, I bitch about it a little bit on the way there, I'm like, man, this is fucking stupid. Like,
That's why you have to drive there.
yeah, but you deal with it, right? You get out of the truck and you like, put your bullshit aside and you act professionally and do the job. You do the thing and like, whatever. But, like, do you think that makes me excited to get up and like, wanna go to fucking work the next week? No.
I think the issue though, is like one of the issues that they're considering is like if Randolph doesn't end up pulling out, considering they're 40% of our calls.
They're not.
has to be transferred.
They're not.
No, they're talking about having Northfield come in and cover Randolph.
We talked about it yesterday at our meeting.
Like, but there's some catches to it. Northfield just can't come in and do our
Yeah,
calls,
no,
cause
that's
they're
what
not a district approved service,
That's
which,
what Linda was saying. Linda was saying that every ambulance in this district has to vote on it.
yeah, it's,
And like, I feel like they would have a hard time, like, there are 3. I know Linda's opposed to it.
it's a little.
Clearly know Matt's opposed to it. So
It's
it
a little
doesn't
more
really matter
complicated
what
on
Steve
that.
says.
Like, they're not so I guess like their goal is like, they're just gonna cover like during the day and at night, or they'll have work cover, and like, is it the same level of care, et cetera, so like, it's kind of like a complicated thing.
We also joke about trying to sell our ambulance.
And there was a period of time that I think the best thing that would have happened for RIPA is taking over South Burlington. But that got shut down by people's perceptions of,
Still an option, we should probably go for it.
we
As
would
long as
love
you
to.
promise to stay out of Tunbridge, go for somewhere else.
It's so it's actually,
I don't think I see why I just want all of Tunbridge back.
there was a lot of pushback from Linda and Pat Cassidy on that. Cause like, Pat Cassidy doesn't like RIPA, obviously, for obvious reasons. She kinda got fucked over by.
I don't remember, I haven't heard any stories, but yeah.
So Pat Cassidy used to be the director here, right? Her and John used to run the agency. They went away on vacation and there was like a coup d'etat, and they were, she was fired, like, pretty much, for lack of better words. And John was relieved of his position as head of service and decided to just be a paramedic full-time.
I can remember that.
It's like years ago, it's been a few years, but yeah, so Pat was not very happy with where about for, I would understand that, like, but, so, anyways, moving on, we can talk after, or on our next break. But, so yeah, I guess like, the reason why that got shut down is like, other services in the coverage area, including like first response agencies, so it's not just like first branch people, like it's, a lot of people were saying that us Swerva paramedics are assholes, and you don't want us covering your town because we're assholes. Which, I mean, they're not wrong. Like, that was at the time when like me and Hollinger were working like every fucking shift.
There's a difference between like
Didn't you
Being
just
a
ask
joking
a few
asshole in
minutes ago for
conversation.
them to change your perception of being an a-hole to someone else?
To limit, yeah.
But you just said you were.
No, but like, there's
No,
a
I'm
difference
just saying
in,
I
like,
can
being, like, a
understand how
joking
my
asshole in
my
a conversation
personality
and
and
not a
Jeremy's personality. Did you meet Hollinger?
Mhm.
Yeah, you can. If you've met Jeremy or I, you can understand how people think we're assholes. Like, even if I'm not being an asshole, I understand I come across as condescending. Like, I understand that about it. Like, that's why Chase doesn't like me, because I sent him an email once, and turns out when I'm being professional on an email, I sound like a condescending asshole.
Like, it's not like an email, but like texting all the time, like it kills me. Like I have to like apologize, like, yo, that wasn't me being a smart ass. Like actually, like I mean that. My
That's
bad.
why you just added a smiley face at the end.
That's why, like, my girlfriend knows that if we're gonna argue, and she's gonna fucking text, she's just better off calling me, because, like, the other day she was saying something, and I was like, okay. She was like, is that a good or bad or indifferent? I was like, just acknowledgement of your message? No. I mean, I didn't say okay, I have standards, I said okay, so an O.
Did the one thumbs up.
No, I
Thumbs
don't,
up
I don't
emoji.
like, I don't like using emojis as a singular means of, like, conveying a
That's all
message.
Chase. Like, if you text Chase, he'll just reply with a thumbs up,
If I,
and then he'll start to type after.
if
and
I'm
try to
texting
keep it
Chase,
easy.
I've somehow gone down an odd pathway in my life. But I'm resorting to First Branch is my only source of, like, social interaction in the EMS community.
It hurts.
I didn't go to become a paramedic to go volunteer at First Branch.
It hurts.
That's why I left Cambridge. I was like, their assistant chief and their training officer, and I was like, no, fuck this, we're better. Now I'm like, we're better. Anyways, so path of this, we're gonna talk about COPD. COPD is broken down in 3 segments, as we talked about. Bronchitis, emphysema, and asthma. We're gonna talk about pulmonary emboli, and all of this is like the itinerary pretty much in the order that we're gonna be talking about things, that's why I mentioned it. Pneumothorax, we're gonna talk about spontaneous pneumothoraxes, tension pneumothoraxes. I clumped hemothoraxes with that. Know that a hemothorax is not a pneumothorax, we'll talk about it if you guys can't figure it out. One is blood, one is air. Pulmonary edema, and then your book talks about hyperventilation syndrome. That's fucking anxiety. I don't know why they're jazzing it up. It's anxiety. Infectious processes, specifically pneumonia. We're going to talk a little bit about cancer and then cystic fibrosis. Cystic fibrosis is just one side. So, chronic bronchitis is where the bronchi are chronically inflamed. It's caused by increased mucus production, and they always have like chronic infections, so it kind of just never goes away. The assessment findings is on auscultation, you're gonna hear bronchi. That's pretty much it. Okay. Increased mucus, that makes sense, right? Rhonchory is the sound of moving through fluid or mucus, which is why you have it. So your pre-hospital treatment for someone with bronchitis is going to be titrate their oxygen sat, IV fluids according to protocol. You can try a duodenum. This is literally verbatim from your protocol sheet. Do you think a duodenum is going to be effective for this patient with bronchorous lung sounds? No, but you can consider it if you want.
We can only do the duodenum once, and then we have to switch
Nope.
to just
Per your
albuterol.
protocol, you can do a duodenum every 5 minutes for a maximum of 3 doses,
And then you can
according to your
just,
Vermont EMS protocol.
and then you can just go to albuterol, right?
Yep, and you
It's
can
just
repeat the
different.
albuterol as many fucking times as you want in the state of Vermont.
That's also every 5 minutes?
Yep, every 5 minutes. So, yeah, feel free to.
I read
you, I know
it.
it's just like this.
One of our pages says you can only use it like once every hour, and then the protocol says something else, and then another page says something else. Like the things we were given say different things,
Yeah.
but I think that's where
You don't have porn up on your
Yeah.
computer, I trust you.
But, yeah.
No, you can see right there, inspiration and authority of Scripture in 2 Timothy chapter 3.
That's what I mean. I'm not, that's why I was not worried about opening up your internet browser of all people.
I did not have the browser up, all right?
I mean, Jackson over there, he's a different story.
Nice job.
He's a deviant.
Yeah,
Alyssa knows, she's in his unit.
Yeah.
midgets will get you every time.
That was really. It's right here.
I know, I'm just pulling protocol itself, so people wanna,
Oh, these are the these aren't the protocols?
Well, this is the newest one, so I don't know if she has the.
Oh,
I
okay.
didn't change the date.
Yeah, so right here. Asthma and COPD. Consider ipratropium bromide 0.5 milligrams and albuterol 2.5 milligrams, aka Adunab, via nebulizer. May repeat every 5 minutes for continued symptoms, maximum of 3 doses, and or albuterol 2.5 milligrams via nebulizer. May repeat every 5 minutes for continued respiratory symptoms. And that's from the 2018 Vermont EMS protocols, literally pulled up off their website. Be prepared for respiratory or cardiac arrest. CPAP, BVM, epinephrine, 0.3 milligrams, 1/1000. That's on there. I guarantee you will never get med control authorization to give a anaphylactic dose of epinephrine for a patient with bronchitis. But your protocol talks about it. And notify the receiving facility that, or consult medical representative. What?
Better ask for forgiveness than permission.
That is true. And I'll tell you a story about that because it relates to airway stuff. I had a fucking patient who needed to be intubated. He was maintaining his own airway. I put an OPA in, had a gag reflex, had trauma, so you can't use an NPA, right? Massive fucking bleed. He had like a huge ass fucking gash in his neck. And I was like, what do? I can't tube this guy because he's fucking still awake. And so I called my control and I was like, can I give this dude a fuck ton of fentanyl? Or Versed to sedate him so he loses his airway and I can get a tube. And they said no, or Copley, because I was still working in Cambridge at the time, said yes. But I want you to give it UVM, so call them and ask for permission. Fucking brand new paramedic, Louboutin, was like, fuck it, I'm gonna follow directions. I called UVM and UVM's like, fuck no, can't do shit. I was like, damn it, now if I show up, they're gonna be like, I told you no. So, yeah, it's always better to just do things. Like, me and Jackson worked as schizophrenic. That was like combative
That was
in the
fun.
fucking Royalton area, right? I gave him Haldol, which is a sedative. If you sedate someone chemically in the state of Vermont, I have to transport you now. Well, here's being a shitbag. So, Loretta, the police chief of Royalton, was like, I'm gonna arrest you and take you to the hospital. I was like, well, I don't know if I can let you do that, but I'm not gonna argue.
He refused to lay down on our stretchers, so.
So he needed to go, but he wasn't gonna go by us. So Loretta's like, I'm gonna arrest you and take you to the hospital. And what would you have done? Ideally, you should call Gifford and see, is that okay? I was like, I got 1 bar of service. I can't make a phone call with a whole bar. Like that's spotty. Cell service is out. Radio didn't work. I just made it up. I was like, we get there. I was like, oh, by the way, PD is bringing me this patient. We're gonna be following them. So sometimes it's just better to defer, because like the protocols actually covers that situation and allows you to do everything offline if like you can't contact med control. So that's my theory, but do as I say, not as I do. Yet, until you get your certification, then you guys can do whatever the fuck you don't want. So, emphysema, alveolar walls, and they rupture and or are destroyed. So that's gonna increase airway resistance. Your lungs are gonna typically become hyperinflated, and you're gonna have decreased area for gas exchange. That's how emphysema works. So on inspection, these patients are gonna be barrel-chested. They're gonna have decreased respiratory excursion. They're gonna be pursed-lip breathing. You purse your lips to, it's kind of like auto-peeping. Did you guys talk about PEEP when you guys talked about CPAP? So you know that anatomical PEEP is 10, right? 10 millimeters of mercury. By auto-peeping, you're trying to slightly increase that by decreasing, or increasing the lumen size, so you're actually increasing the pressure in your lungs. Hyperresonance, because obviously more air inside the lungs, you're gonna have that hyperresonance on percussion. And if you guys don't know how to percuss, you literally take like 1 or 2 fingers and just tap on them, like on the chest, tap on them. You don't need to fucking tap on their chest, that's not doing anything. Auscultations, you're gonna have diminished lung sounds because of the decreased respiratory excursion, so less space for it to fucking move. And you're gonna have a prolonged expiratory phase. And we're gonna beat up the differences because that's a huge section of respiratory emergencies. So for pre-hospital treatment, if you realize, it is the exact same thing as emphysema, or not emphysema, COPD. So I'm not gonna go over it again. So classically, you hear all this talk about pink puffers versus blue bloaters, and that's trying to determine what emphysema, or not emphysema, what COPD they have. Is it bronchitis or emphysema? So pink puffers, these guys, they're kind of frail chest, they're frail looking, very thin, that barrel chest-like appearance. They have like that pinkness of the skin. Versus blue bloaters, you can see that he's a little bit more heavier set, has like some cyanosis of the lips and the fingernail beds. So, emphysemic patients are your pink puffers, and chronic bronchitis patients are your blue bloaters. I always remembered it as bronchitis, blue, because it starts with the same letter. I don't know, little shit like that fucking helps me when I'm trying to remember these things. So, your emphysemic patients are gonna be thin, barrel-chested. They don't have to be barrel-chested, but they could be. You're gonna have digital clubbing from chronic hypoxia. They typically are not gonna have a cough at all. Or if they do have a cough, it's not gonna produce any mucus, because you remember the mucus is all bronchitis, right? And I give you homework from our last call, and I want you to tell me which one this guy fucking was. That patient we took. I remember the gender of it is respiratory distress. And I wanna know which one they had. Breathing assisted by pursed lips, use of accessory muscles or tripoding, because it's a more of a ventilation problem versus a oxygenation problem with emphysema. Hyperresonant chest, they might have some wheezes because decreased lumen size, and you're gonna hear distant heart sounds because of the barrel chest. It's literally all it is. It's like, hey, it's further away, so I'm not gonna be able to hear. Whereas bronchitis patients are typically gonna be a little bit more obese. They don't have to be, but they may be. They're gonna have that frequent cough or expectoration of that mucus, because that's what's causing the problem, is increased mucus production. They're gonna have increased accessory muscle usage because it's harder to breathe and push through, or air and oxygen through that fucking mucus. You're gonna have that coarse bronchi and probably wheezing because of the mucus production. You're gonna have signs of heart failure, such as edema and cyanosis, because eventually your body's not gonna like it, it's gonna be hard to compensate, and it's gonna be hard to tell from CHF. Mainly because of the bronchi, because like, we don't know based off our auscultation, is that mucus or is that pulmonary edema, right? And we know that CHF, one of the causes, or one of the signs is like pulmonary edema. So it's hard to tell the difference. So you kinda gotta look at the big picture, right? They're cyanotic, they're on oxygen, they have that bronchi, they have a cough, or they just kind of do like that to kind of clear their throat, or something like that. Probably more of a bronchitis versus someone that has like maybe hypertension and might be slightly tachycardic, or even just normal heart rate. And they might have those chest pain signs, or some like the other signs of like pulmonary edema, peripheral edema. If they have all of those, you might be leaning more towards CHF versus pulmonary, or versus bronchitis. So this is just showing the bronchial, or the alveolar degradation based off those disease pathways. So emphysema has decreased surface area, whereas in bronchitis, you can see that the mucus plugs up the alveolar duct, which inhibits oxygen from actually, or air from actually reaching the alveolar sac. Does that make sense?
In emphysema, why is there a decreased surface area?
Oh God, wrong way, wrong way. Ah. I don't remember. Oh, yeah, because the walls are destroyed. That's why.
Thanks.
You're welcome. That's my bad. I couldn't remember off the top of my head. Asthma is a constriction of the smooth muscles. So remember that your entire airway is lined with like smooth, I mean not entire, but majority of your airway is smooth muscle. As that contracts due to histamine, stuff like that, that's going to decrease lumen size. As histamines histamine production is increased, you're going to have secretion of mucus. You're going to be able to inhale okay, but you're going to have a harder time exhaling because you're going to have mucus and a smaller lumen size. And so usually they start freaking out, and also because I had asthma as a kid, sucks. The line on my fucking lips thing. I actually had like, for years, an albuterol inhaler prescribed, and I knew that I wanted to join the military at some point, so I stopped getting it filled. And like, cause that's how they get around it, is if you have childhood asthma, you have to have like, I think 10 years of prescription for this. So I was just like, I guess I'm done with this. But, so on asthma, on visual inspection, they're gonna have increased expiratory effort. You might hear about hyperescence because they're able to inhale effectively, but not able to exhale, so they're gonna be trapping that air a little bit, so there might be a hyperescent on percussion. You might hear the rhonchi. I haven't heard it in asthma too much, but the theory is like as histamine release is increased, they're gonna secrete mucus. Maybe you'll hear some rhonchi, but typically you're gonna hear wheezes. And they're gonna have an increased expiratory time because obviously it's harder for them to exhale. So for asthma, these are the patients that are gonna respond really well to your duonabs, to your albuterol, and who did I talk to about duonabs? Was it you two?
Yeah.
We were on shift together. Why do we give albuterol and Atrovent?
Because of the
Not
way,
you guys, you fucking know this, I taught you guys.
One affects the sympathetic nervous system, the other affects the parasympathetic, so you're coming at it from two different directions.
Yes, but let's think it even simpler. They both do the same thing, they're both beta adrenergic agonists, right? They both affect beta 2 cells, one has a little bit beta 1, but they both like fundamentally do the same thing. But why do we give a duonab? Why do we do both? You're just overthinking it, that's probably why you're not getting the answer. It's the onset time and the duration, right? So albuterol has a fast onset, but short duration, right? Whereas Atrovent, or ipratropium bromide, has a long onset, but a longer duration. So the theory is, I don't even know if the theory works, but I know it works. The theory is that you give the albuterol comes into its peak effect, it stays, and then it just drops, right? Whereas the albuterol, or the Atrovent, it might take longer, and maybe at its peak, I probably should have gone more, at its peak, it stays a little bit longer, right? So by the time that the albuterol is hitting its peak onset, the ipratropium bromide should be kicking in and starting to ramp up to its peak onset. So that's why you do both. There's a very inappropriate way to remember it that my instructor told me, and I'm not going to mention that because I said it in EMT class and I got in trouble. So
you told us the other day.
yeah, I can say it on shift because like I'm not in a teaching capacity that I can be graded, but I say so. I've already said some risque shit already, so I'm not gonna be pushing it. Alright, so pulmonary embolism is an obstruction of the blood flow in the pulmonary arterial system by an embolus. I say embolus because most people think of like air emboli, but it could be a thrombus. So it's just something blocking blood flow. So as a byproduct, part of the lungs aren't able to exchange gas. So this is going to cause an imbalance in ventilation perfusion, called ventilation perfusion mismatch. This is from your textbook. I don't know why the fuck you all need to know that. It literally doesn't matter. As a result of poorly blocking blood flow, you're going to get hypoxic because you're not getting enough oxygen, and the degree of distress is going to depend on not just like the amount of lung perfusion affected, but also how long you're in that hypoxic state. Because like even if it's a minor pulmonary embolism, if you're sitting on that for I don't know 12 hours, that's gonna suck as much as if like you had a huge like terminal bronchi or segmental bronchi that was fucking blocked. You know what I mean? So signs of pulmonary embolism are unexplained shortness of breath, tachypnea, tachycardia, hypotension, feeling of dread and anxiety, syncope, diaphoresis, chest pain, pleuritic, not like cardiac chest pain. So pleuritic chest pain is usually you can feel like it's kind of diffused. It's not like the classical substernal. It doesn't radiate anywhere. Coughing or hemoptysis, new cardiac dysrhythmias, or tender and swollen extremities or calves. Why is the bottom one there? Why would you have swollen calves in a pulmonary embolism?
From peripheral edema, from the fluid backing up.
Okay, I like that. What else? think of like DVTs or varicose veins, right? Do you know what varicose veins are? They're like those gross ass veins that old ladies have. It's the easiest way to describe it. And DVTs are deep vein thrombosis, which are like clots that form in like the lower leg veins. You might have those, and those are a common sign of PE because that's like clotting that's happening down the lower legs, usually in those varicose veins. And if a clot breaks, or clot, oh, no, if a clot breaks free, and instead of going to the brain, causing a stroke, or the heart, causing a heart attack, it goes to the lungs, causing PE.
Doesn't usually the uptake go if you're gonna give a negative one?
I don't know.
Or doesn't it?
Probably. I'm not like a.
I watched a video on it on the online textbook. That's why.
Sure.
I'm just curious.
I don't know everything. I'm not a parent god itself. Like, I know that I don't know everything. So, if it's a substantial obstruction, you can experience acute onset of dyspnea, like severe dyspnea, immediately. Hypotension, severe respiratory distress, and hypoxia. So hypotension is like it's including blood flow too, right? So that's going to negatively impact cardiac output, and it could deteriorate quickly. So even if like you try to oxygenate these patients, they need oxygenation, but that's not going to fix the problem. What they need is like that clot to be dissolved or passed. So they definitely just need to go to the hospital. That's what they need. So common risk factors are like DVTs, as we were talking about, right? And you're going to see this also a lot in people that recently had surgery, cancer, if they're immobilized, estrogen usage. Estrogen increases like your body's ability to create clots. Pregnancy, because obviously they're increasing blood capacity. We talk about, you guys will talk about obstetrics, but like female blood volume actually increases by a few liters. Old age, because obviously the body doesn't work as well as it starts to get old, and long flights, and that's more due to sedentariness. So you suspect pulmonary embolism with unexplained dyspnea or hypoxia, and usually in the presence of chest pain, syncope, hypertension, tachycardia, hemoptysis, swelling of one leg, cyanosis, cool, diaphoretic skin, ultimate status, or respiratory failure. So pretty much any respiratory emergency, it tells you to consider that. Which, they're not wrong, but they're fairly obvious when you think it's a PE. Because you won't be able to find any other causes, and through your history, you should be able to gather it. Okay? So for this, if you notice, there's no, I didn't put any of like the albuterol or CPAP or anything. I mean, you could, I guess, try to CPAP this, but it's not, it won't do anything. It's not going to fix the problem. So pretty much all you need to do is just IV fluids per protocol and oxygen titrate, and then transport them to the hospital. Usually pretty quickly, because PEs are bad and we can't, nothing we do pre-hospital can fix them. So they just need definitive care. Pulmonary edema occurs when there's an increase in interstitial fluid and increases the distance of gas diffusion. So essentially, as a fancy way of saying, the lungs fill up with fluid, decreases the time and the ability for gas to be diffused through those membranes. Cardiogenic pulmonary edema occurs on left-sided heart failure, and we administer nitro sublingually or intravenously if you're a paramedic to treat that. And why do we give nitro for this? For like pulmonary edema. It is part of your CHF protocol to administer nitro. Treat it at the
Gives, yeah, makes somewhere for the fluid to go.
How does it do that?
Is it a vasodilator?
I want you guys to like remember the drug mechanism of action. But yeah, increases the lumen size. So if you think about it, there's too much fluid, right? If you make the tank bigger, you're gonna hold more fluid. That's the principle of it. And for any of you guys that work with me or work with medics like you, for example, you'll see, especially on CHF patients, I saw a lot of nitro drips. And people are always like, oh man, that's so hardcore. Like, a good guy is I don't remember his fucking name, Merlin, I think? Merlin? Your guy in First Branch? I've intercepted First Branch like 6 times for the same CHF.
The one from Washington?
Probably fat guy, CPAP, calls like maybe once every couple months. I think his name's like Merlin. Anyways, I always intercept Chase and Linda. They're always the crew whenever they fucking call me at like 11 o'clock at night. Well, this guy's chronic COPD, or not COPD, CHF, super bad pulmonary edema, like poor vascular tone, can never get a line. I don't know. Also, one thing is like, this is the type of patient that needs CPAP. Like, and I know because Alexa asked, how do you know when to give CPAP? And that's something we don't really teach you guys, is like, when is respiratory distress bad enough to need CPAP? Pretty much like, if they're at the, like, they're about to go into respiratory failure, you use CPAP to try to avoid intubations, or if they have any signs of pulmonary edema, that's when you want to use CPAP. Because CPAP is going to displace that fluid by third spacing it. Just push it on the alveoli, not on the like, pleural cavity, and deal with that later. But for now, you can still breathe. So, don't be hesitant on CPAP. The very first time I intercepted with Linda, she was afraid to put this patient on CPAP because she didn't know if it was the right or wrong call. Just do it. If it helps, great. If it doesn't, take them off. So don't be afraid to just jump on that CPAP bandwagon. If you're wrong, cool. The hospital's going to take it off. You'll feel like an idiot, but you'll learn something, right? But people always think like, oh, nitro drips are so terrible. And you can even use nitro drips for STEMIs. And I'm just saying this because knowledge is power, as Alexis said earlier. So the standard dose of nitro is what?
0.4.
0.4 milligrams. How many milligrams are in a microgram? Or how many micrograms are in a milligram? Yes, right? So 0.4 milligrams is 400 micrograms, right? The standard dose that we usually start patients off on nitro are 5 to 10 micrograms. So if we give 10 micrograms as like our starting dose for a nitro drip, we're giving 40 times less nitro than you guys are giving sublingually. And it has the exact same effect because it's going to the veins and it's immediately effective. So if you see us give nitro drips, that's why, because like it's more effective and it's a lesser dose, and we can increase higher without causing as much hypotension or like decreasing in preload. So little tangent for I hope they talk about it in cardiology, but if they don't, now you know. Whereas non-cardiogenic pulmonary edema is caused by ARDS, or acute respiratory distress syndrome, and some toxins will cause this. Organophosphate poisonings will cause this. You hear about sludgeum. Complications of severe illnesses. You rarely see it pre-hospital. It's usually like if someone's sitting in a hospital for a while, they might get pulmonary edema. And ARDS, if they develop it, carries a high mortality rate. So the main reason why ARDS is a big deal is that fluid leaks into the lungs, which makes breathing difficult. And that just happens from a complicated sort of thing. No one really knows what causes ARDS. But ARDS hasn't happened in no, not ARDS. SARS hasn't happened in a while. We'll talk about SARS in a moment. But yeah, ARDS is still a common thing. So toxins as a original lung can cause non-cardiogenic pulmonary edema and damage to the lungs. It may not be evident immediately after exposure. Sometimes it takes a little bit for the body to react to the toxins. And I know I'm teaching your toxicology lecture. I know I'm 90% certain I'm teaching toxicology. So we'll talk about that then. So your pre-hospital treatment for pulmonary edema is IV access, minimize fluid resuscitation. I don't understand why we see so many EMTs and intermediates start a patient on, they just drop a liter into these patients with pulmonary edema when if they're dumping fluid in the lungs, why are you going to give them more fluid? Giving that nitroglycerin as long as their blood pressure is above 140. I say 140, and this is just my personal thing for teaching you guys, right? The protocol might say something differently, but if it's you don't know if it's cardiogenic or non-cardiogenic at your level. Not even my level. We're not doing some fucking blood test to determine the etiology of this pulmonary edema. If it's cardiogenic caused by, let's say, an inferior MI, they have a preload dependency. And if you give nitro to a patient with an inferior STEMI, they will drop their blood pressure by 40 to 60 points minimum, usually, right? So if their blood pressure is at 100, like what we use for our normal level for nitro, and we give them, and then they have a right side MI or something, cool, now you just drop their blood pressure to 60. And can you survive on a blood pressure of 60? No, you just fucking killed your patient. So I'd say like, I believe in the protocol is probably close to 140s. But as long as they have a good blood pressure, like give nitro for it, it's gonna help out. So, and I do not believe for CHF that you guys have a cap on the amount of nitro that you guys can administer. I believe for ACS it says 3, but for CHF I don't think it has a cap. Don't quote me on that, I would say just defer to your protocol and double check. I would do it, but my phone's my remote. CPAP or BVM for moderate to severe respiratory distress. And this is out of your protocol. These are your requirements for CPAP in a patient with CHF. An oxygen saturation less than 94%, a respiratory rate greater than 25 a minute, with retractions or accessory muscle usage. And to use CPAP, you have to have a blood pressure higher than 100 systolically.
For CHF, it says we need to contact med control before doing any of the nitro.
Then it says as symptoms persist.
Yeah, so it's uncapped for CHF only because like the goal is to increase that lumen size to give that fluid a place to go, right? So if you call med control, say I have a patient with CHF, I'm getting ready to CPAP them, can I give them a nitro tab? They're gonna be like, do it. They're never gonna argue with you. He said shouldn't. I mean, if you have Dr. Fran, maybe she will, but
So we give nitro sublingually.
Yep.
How quickly does it dissolve? Should we like be worried about putting them immediately back on CPAP and having, like, it's not big enough for them to really choke on, but like.
So I do not believe in the use of nitro paste. So if you guys carry nitro paste, I think it's a fucking hoax. Because like, your protocol is 1 to 2 inches for nitro paste. That's it. And I'm talking about like, how thin this inch is. Like, what is their transdermal absorption rate of this nitro? And then what if they have an adverse effect? You wipe it off, okay. You just smeared fucking nitro all over their chest, like, now is that a greater surface area? Does that increase transdermal absorption rates? So, I would say, like, if you have the ability to, like, just move the mask, pop it in the mouth, and just fucking put it back on. You can also do some super janky stuff, like, I'll see, next time I teach, I'll see if I can bring in some shit. You can actually do an inline nebulizer treatment with CPAP, but there's no attachment for you, so you have to like do some fucking MacGyvering by like taking trauma shears and cutting the T-piece nap with like the little blue adapter and like medical taping shit together, but you can do inline nebs as well through CPAP. Yeah, I used to carry one of my first bags that I made that worked. I used it for years. Like, just kept washing it. It's probably not sanitary at all, but I don't have it anymore. I threw it away, but I did carry one for a while. So a pneumothorax, that's very simple process. Is there's a hole in the lung, and that air is going somewhere. Right? So a simple pneumothorax is just air can exit, or is limited in quantity. There's no or minimal increase in thoracic pressure, and it just kind of pulls up, right? And then we also teach you guys that there's an open pneumothorax, if you guys remember from your EMT class, and that's like your classical, what we think of pneumothorax is like your sucking chest wounds, stuff like that. That's not really an open pneumo. So a tension pneumothorax is a simple pneumothorax that's got bad. Like it went from like, it's not that big a deal to like, I'm gonna die now. So that increases intrathoracic pressure because as air fills up, you're gonna start pushing that lung tissue down and it's gonna decrease that size. And in theory, it could displace the mediastinum, causing tracheal deviation and JVD. And you get JVD because it kinks those great vessels. The mediastinum is like, it's not a real thing. It's like a made up conglomerate of like your trachea and like your aortic arch and all your great vessels that bifurcate off of the aorta, like your subclavian, your jugular veins, et cetera, et cetera. It's not like a real thing. Like there's no like structure you just point to. That's a mediastinum. That's more like a regional grouping of things. And as you displace it, the theory is you can actually kink that and then cause like cardiovascular problems as well. But if you are at the point that you're seeing those, you missed it. you missed the entire signs of a pneumothorax like a long time ago if you're seeing this. Or you were going to Hancock and you were driving from fucking Brookfield or something. The dude was on the ground for like an hour and then you got found by some hiker or something. You either missed it or it took you forever to get there, right? I've never seen tracheal deviation or at least tracheal deviation with attention pneumothorax. I have seen JVD. JVD is very common. But you can only see JVD at a 35-degree angle in a semi-Fowler position as well. Or not semi-Fowler, but 35 degrees. Typically you want to do it at semi-Fowlers, but half the time you're just putting the patient at supine angles. So the difference between the two is dyspnea is going to be mild to severe in a simple pneumothorax, like cool, they have pneumothorax, whatever. But in attention pneumothorax, and I feel like you two are gonna have like this drilled in your guys' head from fucking DCMT. But like increasing or progressive respiratory distress, hypoxia is gonna be mild to severe and simple, but obviously severe in attention pneumothorax. Lung sounds might be decreased on one side, so that's gonna be your first indicator. Like, cool, I think he has pneumothorax. I can't hear anything. And typically you're gonna think about that in like the presence of trauma, right? If someone just fell off their bike and now you have decreased lung sounds, you're like, I think you might have a pneumo. And you might be, at first you're gonna do what every new provider does, and like, I'm not sure if I don't hear anything or if I hear something, you're gonna second guess yourself. But like in the back of your mind, you're thinking like, maybe he like fucked himself up, I don't know. And attention pneumothorax, you're gonna have decreased on one side, and then on your continued evaluation, you might see decreasing on the other side too. Cause like, your body's starting to like, your lung cavity, or your chest cavity is starting to fill up with air. So chest pain may be present in a simple pneumothorax, because, well, again, they're usually benign, and it's very poor. In attention pneumothorax, that's gonna cause chest pain, because like, you're displacing things, you're moving things, you're filling things up in air. Body doesn't like that, I don't know what's going on, but this sucks.
Is that, if it happened on the, happened to the left lung, could you purposely, whatever you do in the right, bronchial?
Could you
Just
purposely
bypass-
right main stem them?
Just to bypass it?
I think the better solution would be the definitive treatment of like needle decompression.
That'd be,
I think that's more effective, but I
that'd
guess
be
it's,
cool.
I guess in theory you could ventilate that, but eventually I feel like the pressure gradient's gonna increase so much that you're gonna have decreased lung compliance on bagging, cause like if the air builds up so much that you can't actually inflate your lung, like it doesn't matter if I'm ventilating one lung versus the other. So. Yeah, you might have tachycardia related to anxiety or just shortness of breath. It happens, right? We talked about like the stress respiratory mechanism of being short of breath. With an attention pneumothorax, like you're gonna get hypotension, like the very classical signs that we teach you guys. Impaired blood return, JVD, and in the event if you don't correct it, it'll correct itself by dying. But the heart's not causing the problem. You went into hypoxic cardiac arrest. So you're gonna see something called PEA, which is like, you could have a patient that's dead, which is why we tell you guys like, feel for a pulse when you do like your rhythm checks, at least when you guys get to cardiology. They should teach you guys fucking VTAC, VFib, AFib, and if they don't, let me know, and I'll personally teach you guys those rhythms. And STEMIs. If you guys don't get taught how to read a STEMI, you guys are AEMTs now. You guys are gonna be calling in STEMI alerts in the field and giving nitro. If they don't go over that, please let me know, and I'll personally come in and teach it to you guys. Yeah, but PEA is just like, think of asystole, but a normal sinus rhythm with no pulse. Because the heart's still working fine. The heart, it's like, whatever, fuck you guys, I'm still beating. Or it's sending out the signals, but it's not beating because the myocardium's like, I don't have oxygen, so I'm not doing shit. That's pretty much what causes PEA.
Is EMD one of, is that a PEA or no?
I don't know what EMD is.
Electromechanical dissociation, so like with a trauma patient.
That's
is that what-
exactly PEA.
Okay.
Yes.
Yeah.
I didn't know it by the acronym, but yeah, that's literally what it is. Like, think of, or you, and technically, not necessarily, think of, you could also have, EMD could also be like a third degree heart block, where like there's like a dissociation between like the ventricular response and the atrial kick. So you can have like some weird things like that, but usually PA is like, hey, the heart's setting that impulse, but it's not being propagated by like the heart muscle. So. I don't know, the physical findings that might be subtle is a symptomatic, there's nothing else. It's just like, hey, diminished lung sounds, maybe a little tachycardic. I feel like shit. You don't know why. Whereas you might have pulsus paradoxus. I probably should have looked up what that is again, because I will be honest with you, I haven't looked up pulsus paradoxus in like 5 years. Tracheal deviation away from the affected side, hyperexpansion of the chest, hyperresonance. Yeah. So, one of y'all wants to look up pulsus paradoxus?
Is that, did Dave mention that last class?
Isn't,
That's when
is that the closing of the heart rate and
the breathing rate and the pulse rate, they begin to
They
come
come
closer
together.
together and then they cross and continue the other way.
I don't remember, to be honest with you.
It says an abnormally large decrease in stroke volume, systolic blood pressure, and pulse wave amplitude during inspiration.
Okay. So as they take a deep breath, their cardiac output decreases. That makes sense. As I said, I probably should have looked that up. That's on me as an instructor. So pneumothorax is caused by different things. Traumatic pneumothorax, spontaneous, tall, thin young men who smoke. Traditionally could just like be walking down the road and boom. And typically this affects more of the Caucasian demographic rather than African American demographic. African Americans more prone to like emboli, like sickle cell anemia, stuff like that. Clumping of abnormal red blood cells. Or an iatrogenic cause, which is like, we cause that, that's what iatrogenic means. So like central line placement, like, hey, you're feeding a central line through the EJ or the IJ and you pop through a vessel and pop a lung. Shit happens. Or ventilating with too much pressure. Like, if you're like, I think you need all of this BVM. Like, you cause barotrauma, cool, you just cause a pneumothorax. So, inspection, is there a sucking or open chest wound? Do you see tracheal deviation? Is there JVD? Those are all things that like you can just look at. You might also see like, is there a flat chest? Like, that might not be an exact sign of pneumothorax, but that's a sign that might lead you to believe like, maybe that trauma was severe enough to cause a pneumothorax. Percussion, hyperresonance, that makes sense. If there's an increase in air into the chest cavity, then it's probably gonna be hyperresonant. And diminished or absent lung sounds on auscultation. So a hemothorax is blood in the chest cavity, so just replace air but with blood. And it's going to be similar signs of pneumothorax, and it usually tends to like consolidate at the bottom, and then like blood eventually will congeal and clot and just kind of sit there and be annoying and terrible. Hemothorax is it's actually the same definitive care, but not quite. And you can't actually have both. You can have a hemopneumothorax. So if like in a severe trauma, you can actually have both. You can have blood and air accumulating in the lungs. So you could like decompress a patient like me and Jeremy did one day, and just like blood came out. So you could have that happen. Pretty sketchy. So the basic treatment, and this kind of makes sense, right? If there's an impaled object, you want to stabilize it with a bulky dressing. If there's an open chest wound, cover it with occlusive dressing. Because you can't decompress, I'm not getting into the whole like TCCC thing says we don't burp anymore, but civilians still do this, so it's fun. Civilian-wise, they teach you guys that if your patient deteriorates to signs and symptoms of attention pneumothorax, to burp the dressing by lifting up the occlusive dressing, and like theory is like to alleviate the air, and then re-occlude it back down.
Don't you just do a dressing with three?
Nope, they're teaching 4 sides now.
What is it now?
A 4-sided occlusive dressing.
Interesting.
So this is where the military is like far beyond the civilian life. So a lot of like the conflict in Afghanistan and Iraq, and even like some minor instances in like Syria and stuff like that, and like East Africa, have shown that there's no increase in prognosis for a patient with a 3-sided occlusive dressing versus a complete occlusive dressing. And they also showed that burping a chest seal does nothing to alleviate the pressure in a pneumothorax. The only thing that really seems to help is a decompression or a chest tube.
Does the NREMT still want 3?
I would say defer that to Lisa. That's something I cannot confidently answer. I know when I taught my EMT class, all these guys, I taught you guys 4-sided occlusive dressings, taping on all 4 sides. But is that what the NRT wants? Probably not. You're probably just gonna say for your exam, I'm gonna place a occlusive dressing, and no one's gonna question you, and not gonna be like, how many sides are you gonna take? So, how long does class run till?
10.
Okay, cool. It's not a clock. This is the longest lecture I've ever had for you guys, so I apologize. A flail segment. Consider positive pressure ventilation for severe distress only. I disagree with this at a fundamental level because, like, your protocol, this is from your protocols, to positive pressure ventilate, right? But think about that. If you think they have a pneumothorax, what is positive pressure doing?
Increasing the
Fighting.
distress.
It's forcing air in the lung, which is going to eventually do what?
Collapse.
Increase air in the chest cavity, increasing the pressure, collapsing the lung, causing a tension pneumothorax. And you as AEMTs have literally no way of alleviating that tension pneumothorax. So I personally think it's stupid, but the protocol says it, so I have to teach it to you guys. They definitely don't say apply, or they definitely don't want you to put any weight on that flail segment. When I was in
Sandbag.
I just got, they, I remember when we took the EMT class, they wanted us to put like a bulky dressing on it.
no, bulking dressing is fine.
Yeah?
No, when I was in
Okay.
EMT class, like
Sandbag.
they taught us like literally like sandbags or fucking weights on patients' chests. Then again, we also use like mash trousers and like front vents and all these antiquated things. But
Isn't the logic between considering positive pressure to fight the pressure that's already in there? And since you've, if we followed protocols, we were either diesel therapying to the hospital where they can do more, or we've got one of you guys coming.
yeah,
I mean, we've got to get them oxygen for now. I mean, it's not the definitive treatment, it's
Exactly.
the temporary thing,
yeah.
right?
But I feel like in my mind as a provider, like I look at every treatment I do as like the cost benefit analysis. I feel like the benefit I'm gaining is not worth that risk, right? I'm gaining little for what I could potentially be causing. I know that a tension pneumothorax is much more severe than giving my patient oxygen and having them be slightly hypoxic and dyspneic. You know what I mean? Like, that's my mind is like, is it really worth it? But at the same time, at my level, I don't give a fuck. I'll just decompress you. Like, easy. But that's how I thought when I was in A. I was like, is this really worth it? So, you do whatever you guys want. Like, per protocol, there's no right or wrong answer. This is like, that's like beauty about like getting to the advanced level of medicine is like, it's no longer a technician approach to medicine. It's no longer like, if you have chest pain, you give aspirin and nitro, or assist with their nitro. It's like, you give aspirin and you can consider nitro. Now you have like a little bit more leeway to like start thinking about things. IV access obtained. They say give a 500 ml bolus, see how that goes, because you don't know if it's a pneumothorax or hemothorax at that point. So if you give too much, if they're bleeding and you increase like the amount of fluid, potentially you can make it worse. So they say start off small and then go from there. Call for a paramedic intercept. Notify the receiving facility, consult medical control as needed. And my big thing here is like, depending on where you are, like Rutland is, I think, you guys aren't a level 1 trauma center, but you guys are, I think, a level 2. They have like actual on-site surgical stuff for that. Gifford is a level 3 or level 4 community access hospital, right? Are you gonna wanna go to Gifford, or are you gonna wanna go to Dartmouth, which is a level 1? So, think about where you're going. It's better to go to the end care, but at the same time, like if I'm in Randolph, I'm not gonna be like, you're going to Dartmouth. I'm like, no, you're at least going to fucking Gifford where they can put a chest tube. But ideally, yeah, we're gonna be taking them immediately, probably like within 30 minutes. But if you can, if it makes sense to go an extra 10, 15 minutes to a definitive trauma center, you're better off going there. Because in the end, these patients do need surgical consult, and the definitive treatment for a tension pneumothorax, at least, is the chest tube. And I always find it interesting that the way to treat a severe closed pneumothorax is to give them an open pneumothorax. Like, you don't think about it that way, but like when we poke your lung with a needle, right, your chest cavity, we've now given you an open pneumothorax. And then a definitive care too is a chest tube, and that's the same fucking thing. But yeah, it blows my mind. But that's really cool. So we actually are almost done. We're on slide 92. So hyperventilation syndrome, minute volume exceeds metabolic demands. They're going to be dyspneic and anxious. They're going to have chest pain, dizziness. They might be like getting ready to pass out. They might be weak. They might have some paresthesia or some carpal pedal spasms. That's caused by like offending too much CO2. It's an emotionally distressing event preceding the onset of symptoms, anxiety. And there's an overlap between hyperventilation syndrome and anxiety. I feel like this is like, I don't want to go to work, so I'm having a panic attack or claiming my anxiety is acting up. This is like usually where I saw these patients. Like, when I was in Manchester, we got fucking at least like 10 of these a fucking week. And they were always at like the grocery store or like the department store where the fucking lady just got the shift, she didn't want to fucking be there. And I'm sorry, it's a lot, usually females. And it's not that I'm talking crap about y'all just have more emotions than us men, which is true, unless you're like those guys that are in touch with their emotions and all that.
Punch yourself for a reason.
Oh yeah, you should see my typology, like, personality result. It literally said, your personality type lacks the ability to be empathetic. It's like, nice, that explains it, that's why I'm an asshole. So infectious respiratory disease caused by a variety of things, viruses, fungi, bacteria, they can all cause infections of the upper or lower airway. They are rarely life-threatening, although like comorbidities cause like some sort of interaction with that, so take that with a grain of salt. Lower respiratory infections, impair oxygenation, can become life-threatening. And we're going to talk about the big one here, pneumonia. This is what kills a lot of patients, especially elderly patients. So this infection is usually either commonly nosocomial or community acquired. What does nosocomial mean? We talked about medical terminology. Acquired in a hospital setting. So like you go to the hospital for like a surgery and then like you're on the floor with a bunch of like old ladies that have like UTIs and bronchitis and shit, and then you get pneumonia and you're hospitalized for like weeks and you feel like crap. So in pneumonia, the alveoli fill with fluid and blood cells, and it causes inflammation of the lung tissue and the lungs itself. So as such, increased inflammation decreases surface area, available for gas exchange. And if you have a weak immune system, i.e. if you're geriatric, have like immunocompromise, like AIDS, HIV, rheumatoid arthritis, stuff like that, you can actually have death occur because of pneumonia. So the symptoms are going to be tachypnea or a sputum. It's not going to be any specific, they just might have like increased mucus production. Percussion is going to be dull if consolidated. That just means that like decreased surface area as the lungs inflame. You're not going to really hear as much. You might hear crackles or wonki, and that's because either the alveoli filling up with fluid and you're hearing that, or it's causing a degradation of like the actual lung tissue, so that's why you're hearing rattles or crackles. So you'll hear either one. So your pre-hospital treatment is titrate oxygen, 94 to 99 if dyspneic or hypoxic, IV fluids per protocol if they're dehydrated, bronchodilators if your patient exhibits wheezing, inflammation. The theory there is if they're inflamed, maybe it's affecting the bronchi, maybe you'll be able to treat some wheezes with a duoneb. It probably won't work for a pneumonic or patient with pneumonia, but if like you hear them, you give them bronchodilator, it's not going to affect it. And so use that treatment as a rule out for like COPD or something, maybe a rule in for pneumonia. My big thing here is with all infections, you should look for signs and symptoms of sepsis. And we're going to talk about this, and this is the sepsis criteria. You have to have two of the following be considered septic. So a temperature less than 96.8 degrees Fahrenheit or greater than 101, a heart rate above 90, a respiratory rate above 20, an end tidal below 25, systolic blood pressure less than 90, or a MAP, or mean arterial pressure less than 65, or in an acute onset of altered mental status. You have to have 2 of those at least be considered septic. There was another one on there, your protocol is talking about lactate, but you will never be able to obtain a lactate because that's not a thing that we have the ability to do in EMS yet. That's something we're severely lacking behind. And call in like a sepsis alert if you see it. They're pretty severe. There is things called cold sepsis, and that is actually a super interesting thing, and I implore you guys to like do some reading on cold sepsis. I got in trouble during my paramedic ride time as a parapup, and my preceptor made me give a lecture to all of the other paramedics on shift for that agency about cold sepsis and what it is and how's the thing, 'cause I argued with her, there's no such thing. She fucking told me. But yeah. So acute bronchitis is the non-chronic form, so it's not COPD, but it's caused by infection. Inflammation of the bronchi, increased mucus production, it's the exact same thing, but it's caused by infectious processes versus pathological processes that are chronically conducive to bronchitis. So same things, tachypnea, dyspnea. You might have some yellow or greenish sputum. That's very common with like infectious processes. That's why like you're gonna tell if you have a sinus infection based off the color of your sputum, or not sputum, your mucus. Fever, chills, malaise, general like sick signs, and wheezing, because bronchitis, you'll still have wheezing. So exact same thing as before, same treatment for sepsis. And then some of the fringe things are influenza, SARS, which is severe onset respiratory, or severe acute respiratory syndrome. And that was more prevalent in like 2002. Like China had a huge outbreak of this because fucking people living in people living in close proximity to one another with like poor hygiene habits. There hasn't been a reported case of SARS in the world since 2004. So I think it's safe to say it's probably been eradicated by this point. And HPS is hantavirus. It's another fucking thing. That's why we like tell people to wash their hands, and we worry about like infections in the sick or flu season. So it's obviously important for us to get vaccinated for the flu. Even if you're an anti-vaxxer, if you're working in healthcare, I feel like there's a moral and like kind of an ethical like I don't know, priority, I guess, for you to get your fucking flu shot. Because like if you're sick and you're too headstrong to get your fucking flu shot, you're now potentially getting patients sick. And we just talked about like influenza is like you go to the hospital, right? What's the most common thing you can get from the hospital? Pneumonia. Pneumonia is deadly. So you can potentially hospitalize a patient with pneumonia because you gave them the flu, and then they went to the hospital, got pneumonia, and then they died. So I feel like it's your duty as a medical professional to get your fucking flu shot. Some symptoms of influenza is malaise, fever, muscle aches, joint pain, cough. All 3 of us have no excuse because we are forced to, whether we want to or not. Just like you stabbed me, or you drew titers for fucking... I got 3 flu shots this year.
Holy shit. Did you get one at FRC?
Yep. I had one, and I was like, I had the paper for it, and they're like, we don't care, and they gave it to me anyways, and I was like, alright.
My sergeant is making me go to the dental van on April 6th because,
So, I'm gonna pause you there. The dental van, for you guys that don't know, is SRC, is Soldier Readiness Center, and that's where like they make sure you're fit for deployments and shit like that. And they literally just bring in like all these like janky fucking medical professionals. And the dental van is, I shit you not, a Winnebago RV with a dentist chair inside that they do dental work out of. And it's sketchy as fuck.
I thought it was horrifying. They told me I had to get my wisdom teeth out there.
They do everything from tooth extractions, the fillings, the minor dental surgery there, but continue.
She told me that since I have my wisdom tooth, or teeth, but my dentist said that they aren't causing any issues, like they won't ever pop up, like they're fine. But since I don't have that stupid fucking paper that's written down, and I can't get into my dentist until April like 16th or something like that, she said that I'm going into the dental van and getting my wisdom teeth yanked. I was like, I fucking hate you.
Yeah.
I was like, I want to stab you in the eyeballs with forks.
Yeah,
Who is
fuck that. I had,
Go Pete.
I was gonna
She's
guess.
been a
dude, she,
fucking cunt
okay,
since she went to,
I
like-
met your sergeant for the first time when I was, so, I was appointed cadre for that fucking medical symposium, because I know my shit about medicine, and like, so I taught a class on burns and I did that trauma thing. She being a cunt to me, texting through all my lectures and like arguing with me,
Mhm.
going through the trauma lane, and I'm like,
She thinks she's this like big baller since
you
she
work
got
at
out of
CMED as an
C.
evac NCO, like, fuck off, bitch, like, you don't fucking know anything.
She was
We're
like,
gonna see my
she sent me a text. She sent me a text that said, "I'm making you go to the dental plan to get your wisdom teeth taken out." And I was like, "I don't think you can make me do shit." I was like, "If they're fucking
If they're
going
rock,
in,
paper, rank, she can make,
I'll go straight to my first sergeant."
just like, do you guys know Kamoli?
Yeah, she's a piece of shit.
Yeah, she fucking,
Sorry.
so like, we were,
I didn't know Kamala.
we were doing the whole, like, you guys weren't there because of the fucking, that's the day you guys did IVs and shit.
Mhm.
We do like, pretty much like the,
Trauma.
yeah, but I forgot what it's called, the Mystic Simulator, it's like where you fucking go in the blood lab and stuff.
Mm.
We were trying to tell you guys, like, hey, gain firepower superiority and then advance up. And like, Kamoli just fucking went up and started treating the casualty. I was like, you're being shot at, you know, firepower square. She goes, I outrank you. I was like, alright.
She did?
Yeah, I was like, fair enough.
Alright.
Sergeant McGraw, in E7, was like, well, I told you to do this, and I outrank everyone here except Master Sergeant Sprano, so if they have an issue, tell them to come find me, and I'll sort it out for you. I was like, roger that, Sergeant.
She's awful. She like never does her hair correctly, and that was the first thing that turned me off about her. I was like, fucking fix yourself.
I love our new sergeant. We have this new sergeant named, I'm waiting for her to get back now. I was waiting for you to get back, that's why we were sidetracked. We have this new sergeant named Sergeant White.
It's like only one hat.
He's been in the army for like 10 years, like deployed multiple times with 82nd Airborne, went through like RASP, did full SOCM course, like has aerosol, airborne, some other fucking thing. But like, pretty high speed dude. He showed up to his first drill in the guard with like no fucking haircut, didn't shave, like his name tags were falling off, like he showed up to our winter FTX or STX with summer boots on.
I heard about that guy.
Is that the guy who has like, who's like, oh no, that's different. Who's the guy who's like, he has a Ranger deployment tab and he's like a little chunky and overweight
No,
and
it's
never
not
has a
that guy.
haircut.
It's just, he's just,
Yes, he's chunky.
this guy's not, but like his, I call him Snaggletooth, he like has some fucked up tooth.
Oh, you do?
Yeah,
Okay.
but Lieutenant Colonel Biggie showed up and was like, so, you know that this is winter, and the entire brigade requires you to, wear either 12 bars or approved cold weather footwear. And if you go to the field, you know you probably want to use boots that are so clearly evident not winter boots. Because he was wearing like fucking Oakleys, like
Oh.
the fucking like summer boots. He was like, yes sir. And like, he fucking runs outside, comes back with a brand new pair of Toro Boros. I'm like, where the fuck did you just get these? I have no idea where he just actually acquired these. They magically appeared out of nowhere. Cause like, he drove in my FLA, I saw him pack his bag, there was no Toro Boros. He somehow,
the tree.
within like 5 minutes, this kid had a pair of Toro Boros.
He had them
I'm like,
airdrop to him.
I'm like, and I don't know, man, but he's a funny dude. But yeah, he's just like that. Like, first impression, he looks super fucked up. But then, like, we're sitting there doing our like, pre-JRTC brief, and he's like, we're attaching him out to a fucking line unit. He was like, so you're gonna send Sergeant White, all known as the solo medic, for Charlie Troop, who's gonna be getting their dick pushed in on a firing range, with no ability to call in airstrikes or anything like this. He's like, can Sergeant White get like a M240 or a 249? I'll carry that bitch on my own. And they're like, nope, you can't have that. He was like, fuck me. But yeah, and then he found out that the Colorado guard is air assaulting in for fucking our JRTC appointment. He was like, can't Sergeant White static run out of a helicopter? He's like, he's not on the 82nd anymore. But anyways, moving on. Lung cancer, primary cause, smoking. Exposure to asbestos. What is it? Mesothelioma? As all those commercials talk about all the time.
I'm the lawyer.
Genetic predisposition. Sometimes you don't smoke at all. You live in a bubble that's asbestos free. And you still get cancer. Sometimes you're just fucked. So there's two types, small cell, non-small cell. Stage of cancer is based on the degree at which it's metastasized. 0 is localized to one area. 5, extensive metastasis, which means like, if you guys don't know what I mean, metastasizing lung cancer, or any sort of cancer means like, hey, it started off with the lungs, but now you have toe cancer. So, that sucks.
Get measured for a box.
What?
5, get measured for a box.
So, I mean, yeah, probably. Unless you do like full body like chemo. Like radiation, not like the actual take med chemo. Lung cancer, when you're trying to respond to lung cancer patient, you're often going to deal with, this is verbatim from, this is an example of not my slide. This is your textbook teaching instructor's slide. I just copied and pasted. When responding to lung cancer patients, you will often deal with issues of death and dying.
I did that.
Be cognizant of the stages of grief. Patients may be on hospice care and have this was actually a DOLST form. I don't know what the fuck that is, but instead of Vermont, we're badasses, we use a COLST form. Or a DNR. Patients may have respiratory depression and hypotension caused by high doses of potent narcotic medications.
So this is kind of to do with this. I didn't know what hospice meant. Like, hospice is when you like go home and die, right?
Yep. Well, you could have like actual in-hospice or in-hospital hospice care, but like traditionally, like
Yeah.
if you're on hospice care, it means you're dying and they're putting you on like comfort care measures.
This lady, we were transferring her to home because she had end-stage renal cancer or something like that, and I didn't think of it. I didn't look at the transfer paper. Like, it was almost end of my shift.
And when you left, you said, "I hope you feel better."
And I was like, I bet you're excited to go home and like see your family and see your cat. And she's like, yeah. And then I was just like, I bet your like animals are really excited to see you, and like you're gonna sleep in your own bed and blah blah blah, and like really like pump her up for it. And like then I like it clicked when we got to the thing, and she wasn't going into her own bed. She was going into like a hospital bed, and then I was like, oh fuck, she's gonna die. And so like I didn't know what to do, so I was just like, enjoy being home.
Yeah, I've definitely done that because like I just teach myself like patient empathy because like I don't usually don't care about patients. And like early in my career, I definitely used to leave hospice calls and been like, hope you feel better, have a great day, with a smile, and they'll like leave. And I'm like, the family's fucking sobbing, and like, another good example is like, and this was like, I kinda don't wanna say this, but this was recent, like within the past 2-3 years. Me and another paramedic, we dealt with medic to cardiac arrest, and we're sitting there waiting for the ME to get here, and we're hanging out. It's like 6 o'clock in the morning, and the family's like, "Can we get you some coffee?" And my partner at the time was drinking decaf because he was trying to be healthy because he's a douchebag. And I was like, "Oh, sure, I'd love some coffee." My partner's been making decaf for the station. It's killing me. I didn't catch it, and they didn't seem to catch it. My partner caught it. We're driving back, and he was like, "You're an asshole." I was like, "Why? What did I do?" Completely ignorant to the fact I just said this. He was like, "You just said the decaf coffee is killing you to the family of a patient we just coded." I was like, I can see that. But so cancer patients may suffer from a variety of other health problems related to the progression of the disease. Behavioral changes may be due to brain metastasis, hypoxia, and side effects of medications. Pathological fractures may occur as a result of loss of bone material. Cool. You guys understand that cancer sucks, right? Can spread places, and now it's no longer fucking lung cancer, it's body cancer, and the body doesn't like it anymore because it's dying. So cystic fibrosis, y'all will probably not see this. Like if you work in a hospital, you guys will see this shit all the time. Like I'm pretty sure Liz, like she talks to me about this shit all the time, and I just tune her out. She's like, I did another CF patient today. I'm like, I don't care. But it's one of those things you listen. It's happy wife is happy life. So, it's a rare genetic disease of the secretory glands that cause extremely viscous mucus, very thick, and like it clogs the organs up. They obstruct airways, and like they have to be fucking suctioned, and it's super gross. If you've ever seen one, like it's like the most amount of fucking mucus you're gonna suction from a patient. It's gonna be cystic fibrosis patients. It's super disgusting. It's thick and you have to treat it with humidified oxygen to like loosen this shit up so you can suction it, which is still gross. It just increases the volume at which you're suctioning. IV fluids, CPAP, nebulized bronchodilators for wheezing. Like literally just you have to consult medical control because like you gotta figure out what they want to do and what you can start to help the hospital treat these patients. This is one of those patients, if they said they have CF and like they're having respiratory distress, call the hospital and be like, hey, you need to get respiratory because like there's no way the doctor's gonna want to dick around in the ER for like 30 minutes suctioning this dude's airway. They're gonna send the poor little if I can do it. Flexible here. So this is your AEMT wrap up. So at this point, I didn't know how to like, your little thing inside the book kept using their names, and I was just like, I don't understand it. So I just replaced all of their names with the word AEMT, so that's why it looks super derp. So AEMT treating a 60-year-old male, or 60-year-old history of COPD combining respiratory distress, fever, confusion, and a productive cough. Based off that, what do you think's going on? Which COPD is he? Productive cough, fever, confusion, respiratory distress?
Bronchitis.
Bronchitis, boom, below that.
Okay. Patient's hypoxic. Breath sounds are wheezy, rhonchi, and rails. What the fuck? Dude has all of it. And he has pedal edema. Okay. So based off that, do you still think it's bronchitis, or do you think it's potentially pneumonia as this guy thinks?
Probably.
I think pneumonia,
Why?
wheezing. Is that with both?
That's with
No,
both.
There's
Okay.
there's one word I'm personally looking at that like leads me to believe pneumonia versus bronchitis. Patient's febrile.
Oh.
Fever.
Why would you be febrile with bronchitis? Unless there's an infection going on, right? Don't overthink it. Like sometimes it's like a super simple answer, like, oh, he's sick. Cool. So you're suspecting pneumonia for this now. So you administer like a good EMT or AEMT. You administer high flow oxygen via non-breather. It helps a little bit. So, IV fluids can help with hydration because he's probably infection. He probably has an infection. Maybe give him some IV fluids. But you also like worry that hey, he has pedal edema. What if I'm wrong and he doesn't have pneumonia? He has heart failure. So you somehow come up with this miraculous 30 mLs of 0.9% sodium chloride per hour. I don't know how the fuck, what math they did to come up with that number. If y'all tell me that I'm going to start a normal saline drip at 30 mLs an hour, I'm going to be like, you're an idiot. Like, one thing in the hospital when you guys put on the fucking pumps and you guys have to have like drips, in the field, you adjust like, hey, you're getting too much. We just kind of turn it down a little bit. Or you count the drips a little bit. It's adorable when you go to transfers and I'm like, oh, there's IV fluids running. Okay, what? Saline? Take that shit off. You don't fucking need that. Very first thing I do on ACLS transfers from Gifford Medical Center, take them off the fucking pump for saline. Stupid. Administer 2.5 milligrams albuterol to treat bronchoconstriction. That's because he's wheezing. So after albuterol, the patient's wheezing is remaining dyspneic with rhonchi and rales. SpO2 is 85 and is becoming more exhausted. Okay, so he's becoming more exhausted. What would you guys want to do?
CPAP.
And I kept that portion in here because that answers your question a while ago. Yeah. So you recognize impending respiratory failure in the presence of rhonchi, so you know there's fluid buildup, right? So you're going to start CPAP at a PEEP of 5 to 10 centimeters of water. Don't go to a PEEP of 5. Atmospheric PEEP is 10. So if you give a PEEP of 5, you're doing fucking nothing. 10 or 15. That's just your textbook being stupid. Okay?
Opposite of what another provider told us when they were teaching.
Well,
Yep.
atmosphere PEEP is 10. That's how much PEEP
It
you
makes
use.
sense, I'm just saying,
Like,
opposite.
it's just like, would you give a patient 2 liters of oxygen to be a normal breather?
No, that's good.
Yeah, why? Because that's less oxygen than room air,
Yeah.
right? Why would you give a people 5? Well, you're assisting with their atmosphere. No, fuck off. Start them at 10. That's what fucking atmosphere is. Like, don't pussyfoot around it. Like, sorry, that's probably not politically correct, but for real. Start them off at fucking 10. That's your protocol, I believe, says fucking 10. Pisses me off. You can't tell I have like a little few triggers in EMS.
Pete
PEEP is one of them. I had a fire department that did PEEP in Manchester, and they would fucking like, they had like the classic fucking yellow pump thing, and it was just based off like a colored bar. And I would always ask them, like, when I was first starting, I was like, how much PEEP you got? And they were like, the bar? They had no fucking idea. Like, they just like put it on, and like, it's good to go, he's fixed. I'm like, thanks. So this is like a kind of realistic case study that I actually want you guys to think about. So you have a 50-year-old female complaining of left-sided chest pain and dyspnea. Patient reports hemoptysis. On impression, your female patient is very anxious, agitated, frightened. She says that she's dying. She appears to be overweight with pallor, but not grossly cyanotic. She has rapid, shallow respirations. Her vital signs are 130. Her respiratory rate is 40 per minute, and her BP is 90/60. What are your differential diagnoses? I just want to know what. Okay, you think PE? What else? What do you think? I'm gonna literally ask all of you.
Going for anxiety, hyperventilation.
Okay. What do you think, Jackson?
I was like with embolism.
What do you think?
I was reading about PEEP. I'm catching up.
Okay. Then I'll come back to you. What do you think's going on?
Embolism, hemotherapy.
Okay. But hemo. Hemo/pneumo. Because you can't tell the difference? What do you think?
I was gonna go with anxiety.
Right. What do you think?
I think PE.
Okay. But, so you have 3 different potential causes, so you guys probably need more information, right? So, there you go. Onset of chest pain about 36 hours prior, that's gradually gotten worse. Over the last 2 hours, she's developed dyspnea and hemoptysis. Physical exam reveals decreased chest excursion on the left side, diminished lung sounds on the left side with diffuse wheezes. A pleuritic friction rub is noted during inspiratory and expiratory phases. Does that change your diagnoses at all?
It gets rid of PE, doesn't it?
Huh?
It gets rid of PE, right?
Oh, okay, so we went from 2 people thinking PE, so what do you think it is now?
Go more towards hemopneumo.
Okay, so actually I'm gonna keep those numbers. So you now think it's hemopneumo, what do you think?
I'm not sure yet.
So do you just wanna keep your current? Or I'll come back to you. Jackson,
Pneumo.
you think it's a hemopneumo now? Okay. You thought,
I thought pulmonary embolism.
There were 3 PE before.
oh, was there,
Yeah.
okay. So, you thought it was PE, you thought it was,
I think it knocks out anxiety.
Okay.
I think the blood.
So what do you
pressure
think's
knocked out
going on now?
anxiety.
Right. Do what?
I thought the blood pressure knocked out anxiety because then it's really.
Being low.
Yeah, I would think it would.
but she was
it would
tachypnic
rise.
and tachycardic.
Yeah. That's,
So,
I don't know. Okay.
but, so what do you think it is now? If you don't think it's anxiety? There was 2 for anxiety, so now there's 1.
Oh no, I didn't say anxiety
No, that
before.
was anxiety, so you could take one off anyway.
I think this is all just getting confusing.
So, anyways, whatever, you don't think it's anxiety anymore?
I think we eliminate anxiety as an option.
Okay.
That's all I was saying.
I think
What do you think it is, Charles?
I wanna stay with pneumo, but maybe go to pneumonia.
Okay. So now we have a new diagnosis. What do you think? You're not the last one, so don't worry.
Hemolymph.
Okay. Has your diagnosis changed at all?
I still think there might be a possibility of me.
Okay, cool. So that's the great thing, right? So we're gonna talk, this is where like, I'm gonna get to that weird thing and then I'll finally tell you what it is. So you do an EKG just to rule it out, right? And this is what you see. And this is where I said at the very end, there's like this advanced shit. So you see a sinus tach, which, that makes sense, right? Her heart rate was elevated. She was at 130, this is 140-ish. But you notice that she has some septal ST elevation, so what do we know with ST elevation? Now there's like, as 8 EMTs, you guys would be like, oh man, maybe she's having a STEMI now. So that adds another fucking diagnosis to your list. With anterior involvement, that's the proper way to write, and this is why I said like it might go over, but I'm not talking how to read it. And T-wave inversion happens with like you have ischemic changes, so like the heart doesn't have oxygen. So, okay, that's all cool. We're going to talk about this in a second, but so we talk about what do you guys think is going on. Before I give you guys the answer, how would you treat this patient, regardless of like what's going on?
Per protocols, we'd give oxygen.
Okay, oxygen. How much are you going to give?
15.
15,
So,
would be
oops. Okay. Oh shit, I fucking tried going back to the front.
She was at 80, what was it?
Okay.
Huh?
SpO2, I didn't grab one. This is a hospital patient, so they didn't put her.
Well, her respiratory rate's 40 a minute, so we're gonna go 15.
liters.
You're gonna go 15, be a non-rebreather? Or are you going
No,
to,
not
or are you gonna
non-rebreather.
BBM her?
BBM.
Yeah.
Would you do a duo nub with it?
Sure. Alright. You give it a duo nap. And that's because,
Hypoxic and wheezing, which points to bronchoconstriction, I think.
Mm-hmm.
or the fact that she had diffuse wheezes.
That too. Well, yeah,
Well,
that's what I said.
That's what he said.
Gotcha.
But yeah, I didn't hear that. I wasn't really listening to it. I was looking for the side lines.
No empathy.
You can start a line and
Okay.
do a bolus, I guess. Yeah.
Okay. What else you guys do? Is that it?
EKG.
You did an EKG. Your EKG was this guy, and you saw signs of a STEMI.
But you can't give any nitro because her blood pressure is so low, right?
Okay, but what can you do?
Aspirin.
I thought our protocols had aspirin only for cardiac related chest pain.
We done those not cardiac.
But
Well, I know we,
I'm running this as if like this is a true EMS call. You find things out, right? So if
but
you have
she
a
didn't,
STEMI,
she didn't report cardiac though, right?
no. But if she has a STEMI, what is a STEMI?
But we can't act on what we see.
But the monitor will
But
say
the
The
something.
monitor will
will tell you
print
it's
out.
STEMI.
It won't tell you what this is, and I'm going to talk to you guys about.
Okay, did the monitor say STEMI?
That's why I put it on there. Yes.
Okay.
I acted as if this was a fucking readout. I just didn't put. I forgot that the monitor does the asterisk, 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 and QNMI suspected. So based off that, you guys would probably follow. You'd be like, maybe I'm wrong. Maybe this isn't a respiratory emergency. Maybe this is cardiac, and you start going down your cardiac protocol too, because like you treat the patient, not your protocols, right? So you give them aspirin. Is there anything else you would do? You wouldn't give. You'd consider nitro, but you wouldn't do it.
In terms of blood pressure, how about?
But no, due to BP or SBP.
We can
So I
consider
was talking to Charles about this
epi
too.
for STEMI.
At AEMT level, when you guys document, you guys should say you consider things like I consider an IV or I consider giving nitro, but I wouldn't do it because of this.
No, we can
or-
consider epi for cardiac issues too. No arrest.
Yeah.
Only arrest.
I
Never
was
mind.
thinking, I was like, where are you going with that? But no, yeah. If she died, fuck yeah, give her epi and shock her. Cool. Well, so this is in fact pulmonary embolism, right? The classical signs there of like a pulmonary embolism. And what gave this away to me was the acute onset chest pain, sure, gradual onset of chest pain. She had some chest pain, right?
On one side of her chest.
It didn't say that, it just said onset of chest pain, 36 hours, has gradually gotten worse. Okay, so she had chest pain. You guys can't tell if it's, we can't even tell, we just think it's chest pain. That's how we get told, right? With an acute onset of dyspnea and hemoptysis, the only clinical thing that we talked about, or pathophys option that we talked about that had coughing up blood, was PE. So that's the classical sign there. And obviously you probably would have asked more questions of this real patient, like, have you been out of the country? Have you been on a plane? Have you been on a train? Et cetera, et cetera.
Surgeries, all the whole thing.
Yeah, you probably would have asked
I'm
a
Dr.
lot.
Seuss asking questions.
What was that? You're not the ones asking questions.
No.
It's
But-
not like Dr. Seuss questions.
It's
You
not
were-
Dr. Seuss questions, but
No, you were rhyming quite nicely with it, that's why I
oh,
said
cool.
that.
Then it wasn't intended, but let's say it was intentional. But cool. So in this patient, she would have had a DVT, most likely. That would have had a thrombus that came up, went to her lungs. So the instances of that happening are like 1 in 2,000 patients annually. It's not a lot. Obviously, as I said, like elderly population, mobility, recent surgeries, clotting imbalances, all those impact it. So emboli circulates through the blood, through the right side of the heart, through the pulmonary artery. If the clot does not dissolve in the lung, it could occlude the pulmonary artery or obstruct the blood flow and perfusion of the lung, which can be fatal. And the reason why I use, oh shit, I have the red line. The reason why I included this EKG is this actually has a super cool thing in here, which is like, if you guys went to the district meeting, I talked to Dr. Fran about it. It's called S1 Q3T3. God, I can't write. Like a little kid. So, this here is called an S wave, which is a negative inflection on your previous complex preceding, or like after a positive inflection, because QRS is actually just like, there's different types, there's RS, ROAs, QAs, shit like that. And then in lead 3, you see a Q wave, which is the little fucking negative inflection prior to a positive inflection on the QRS, and inverted T waves in lead 3. And studies have shown that patients that exhibit all 3 signs of these, which are very minimal, it's like 20% of all PE patients, only patients with PEs have those 3 findings. And those 3 findings cause enough coronary ischemia to mimic a STEMI. It's literally a STEMI imitator. So you will see signs of a STEMI. So like, when you talk about STEMIs, this here is called the isoelectric line, what I fucking drew there, right? And that's the basic level of cardiac or like threshold.
I think it's on your shoulder.
Is it? No, it's not. It's fucking right there, guy. Fucking right.
Okay, I got it now.
Oh.
You can't see where you're drawing, there's no mouse to follow.
Oh.
It's just drawn.
Okay, yeah, so I drew that red line there, right? So that red line, I just used it because that's the one where my fucking mouse was right here. And it is the isoelectric line. So if you notice, this here is called the ST segment, and that's where the QRS complex goes to make the T wave. Like right before that, it's called the ST segment. In STEMI patients, that's elevated. So that's what we talk about. STEMIs, that's what becomes elevated. And what you look for is, and like, there's these things called reciprocal boxes. So, and this is going up above and beyond. This is why I said, like, if y'all didn't want to be confused, y'all can fucking leave. But if you guys want to learn some stuff, like, stay a little bit. These leads here, granted, I'm sorry, I'm not a fucking artist. It's so bad. Can I change the color? We'll do blue.
So would that be a tombstone T wave?
Oh, I'm gonna go for that in a sec. I'm trying to block, like, take everything except ADR, is what this is trying to say. So, if you, I'm sorry, it looks stupid. So if you see elevation here, right? Here, 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 or here, you should see depression over in these leads, right? And if you notice, there's some depression here, like if I were to make this line straight, using my phone or whatever, right, you see how that's fucking depressed?
Yeah.
Like, that's reciprocal change, so, the reason for that, I'm not gonna get into it right now, but these things have reciprocal changes, so if you see elevation anywhere in 2, 3, or AVF, you should see the opposite in anywhere else in the heart. Whereas if you see depression here, you should be looking for elevation on the other leads, okay? And actually based on where it is in these leads, you can actually determine what side of the heart is affected. What else? Also to call a STEMI, you have to have contiguous leads. So if you have ST elevation somehow in lead 1 and lead 2, you can't call a STEMI because those aren't reciprocal to one another, right? Does that make sense? Whereas if you have elevation in 2 or 3, or 2 in AVF, these are all the same sections. So like if you have elevation in any of those segments, you can call STEMI. But, yeah, so, that's why it's a STEMI imitator, because if you notice, the isoelectrical line is elevated, or this section here is elevated to the isoelectric line.
So if we can't read these, so if we were to call a STEMI, like,
You
not
guys,
that I really care.
I'm
what
a
happens, but,
personal
like, with a
philosophy that
hot-
all AEMTs should be taught how to read STEMIs, because that is something you guys will see and you guys will have to manage. So the core thing, like, you guys should learn how to read STEMIs, and I'm pretty sure we teach you guys. And if not, I will teach you guys. But what's your question?
What would, like, I don't really care if the hospital's mad, but like, would they get pissed off if like you call a STEMI and it's not, or is that just, like, ignore it and look over it?
So,
Like, if you get there and they see this and they're like, well, is that, it's actually a STEMI, like,
that is why,
not that it hurts my
yes,
feelings, how they-
so it depends on where you go, they do care. Like, if you were to go to like Dartmouth or UVM and call STEMI alert, they're gonna clear out a cath lab suite, and they're gonna like call people in, and like, you're gonna have a fucking whole mess of people there waiting for you. And if you get there and it's not a STEMI, you just activated a whole cath lab and maybe deferred a patient from getting a procedure they needed. So my way around it is I always tell them, like, my patient has 2 millimeters of elevation and needs 2, 3 AVF. And that's why I say you guys should learn how to read STEMIs. Or you say, like, my monitor says acute MI suspected or something. So you're not calling a STEMI alert, but like you're saying, like, this is what I see, you make the call, cause like, I don't wanna get in trouble, right? So, but there is like, we do teach you guys, like, the state of Vermont wants you to call STEMI alerts, but like, that's not realistic, cause unless you know it's a fucking STEMI, like, it'll be obvious. And he talked about something called tombstones, that's literally like, if instead of it being like this, it would be like fucking something like that, right? Like, it'd be fucking obvious, they look like fucking tombstones. But that's why, like, you would think that your monitor's not gonna know the difference, the monitor's gonna see those changes. And that's why EKG monitors are kinda stupid sometimes, cause if it notices something, it's just gonna tell you, like, I think there was this heart attack going on. But we know as providers, like, it doesn't really fit the story, it could be, but it's probably unlikely. So, take everything with a grain of salt, but it's pretty cool. EKG, that I just had lying around, so. Cool. That's all I have. Any questions? So our class took forever today. It was a long and important lecture.
Review.
What was that?
We'll reflect in your review.
This is the first class I've taught that I've literally almost gone to your dismissal time.
I just got them walked out at 10 o'clock. No questions asked.
Well, I mean, we probably spent like probably 15 minutes talking about things that aren't pertinent to. No, I mean, not like our sidebar, like, I mean, like, what we just did was definitely not pertinent to fucking